Good evening, everybody. I am very much grateful to the organizing committee for giving me
when office leave is normal,
that I was speaking in the market representation is defined are in levels with all the necessary what people like to live in the vertically, but that practically of hypertension on APP, that APP, more create for the has APP, more than what the people like to find and see APP, more than on the but not this is the final repeating numbers. All the superiors and of course, what would be like 90 level already, but that's what they are doing. How to do that hypertension. Luxury and not repeating, make up every part of hypertension. And we people are services. And necessarily and here resilience but they resistance limits. It was equipment, software analysis, and what you want to start this year behavior. People are and certain higher level research is and does require success. In that case, you are successfully required. Nighttime is stronger with better than I was thinking or doing like In India, the hyperpolarization is very increasing the last 60 years. What you look at are that the hyperpolarization is 3.8%, and it is 6.7%, and 29.8% is estimated that hyperpolarization accounts for 10.8% of all universities in India. But the Philippines has one hyperpolarization in the population is 1.52, which is 80.6%. If I up to 20.0%, at 2%, the Philippines was 8.5% in the federal study. In a study conducted by the 8.0%. It also much unlevel in a study conducted by the Whitehall in the United States, the what does it mean? The overall this smart percent, it becomes 5%. It means half of the population is suffering from actual hypertension. The two sectors that are heavily subject to experience mental illnesses and more sevens excessive that is the likelihood chronic and obstructive sleep apnea. Someone wants to say it. Mental illness at work or at home, maybe these people working hours. Since the of this will not be values while response. Of such a is with solid time characterized by isolated nocturnal hypertension. A significant hypertension period of hypertension from a population population. Increased target sometimes under the hypertension population group. The natural opportunities and acceptable resources are an important outcome. After the meetings and discussions on the cause of the it has been accepted. Why could hypertension and hypertension are associated with some negative impact on cardiovascular outcomes? Cardiovascular mortality and stroke mortality will increase to the same degree in group and sustained hypertension in comparison with long-term subjects. That isolated ability much factors. But subjects and was higher than the hypertensive and hypertensive. The first finding was the stage at March increased risk of cardiovascular mortality. This finding will confirm in a research study that association in places and March hypertension. March hypertension like the greater weakness than the document. This is an observation that I really get some of the especially to give a aggregate of the damage. One analysis of the 80% shows the existence of influence to the master hypertension and you can set a higher point to almost same in the hypertension. The instance of hypertension almost same. This analysis Cardiovascular indicators in untreated March hypertension is indicated than untreated non-hypertension. And these cardiovascular indicators are much lower in 80% of hypertension on treatment, not to people that is the cardiovascular are much better than treated non-hypertension success. Because it's consistent hypertension that 2013 European Society of Hypertension Society of Cardiology that success. The in the assessing cardiology and assessing initially, exercises, lifestyle exercises decrease and normalize and usually done also the if it fails, of course, initiated as on the high analyzing, it has up to 30% of it and for March hypertension. But 50% of hypertension maybe March hypertension. Hypertension, but he was seen to take March hypertension and which the and exclusive already 4% of the much population that treatment is uncontrollable. Bring in programs. Based on current hypertension guidelines, advice performing and exercises and possible. In already created hypertension, control of toxicity and reduce target organs. As target organs, treatment and if there is target organs, this is assessment. If you consider hypertension on ability levels of measurement. This is March hypertension. And you will shift the combination of treatment. If it is 150 by 90, this is hypertension. And if you ability levels of measurement on ability levels of measurement, yes, this is resistant hypertension and this has the criteria of hypertension. This is hypertension and I treat it accordingly. Office material and also now. And such as hypertension. March hypertension makes the susceptibility individuals high but and one technical point is that this is such a good rather than this is in him and in the monitoring. This should be applied to some others and which will be in the frequency range. But the potential on the market represents but the optimal electricity taking the process is not yet clear. I'm looking at this as I mentioned, I will policies in and diagnosis of sensitivity, but that's not this is the rejection to realize all electricity as I mentioned, and clinical practice, but it is not complementary to ambulatory assessment, not assessment. When hypertension is started in case of hypertension, hypertension. I you know it is unmasked with mass hypertension. Thank you. Thank you for the sincerity. About hypertension last time. I usually talk to you what are the factors is that can mask the hypertension. Actually, there are most factors, but certain conditions like also condition that make master hypertension.
It is clear this is much. 30% around is much. It is associated with target organ damage and increased mortality.
If at all it is associated with target organ damage, I prefer to go for ambulatory blood pressure now.
Okay. So if any comment or any question from the audience,
Dr. Mrityunjay, I have a comment. I have a comment.
Yes,
Sir, I'm here. Sir, so what is taken that among the white coat hypertension and masked hypertension is more injurious?
Of course, masked hypertension is more injurious than white coat hypertension.
That is one important take-home message.
much dangerous.
Thank you. Thank you.
With this, we have come to the end of the session, and I would request PK Agarwal to be on the stage.
Thank you.
Thank you so much to each one of you. I will request all of you to kindly remain on the stage, as once again we are going to have a felicitation ceremony over here. And now I will request our honorable chairperson for this particular session, Dr. S.K. Goenka from Begusarayi, to kindly come forward and honor our first speaker for this session, Dr. Abhishek Kumar, sir, from Patna. Let's have a huge round of applause for Dr. Abhishek Kumar, sir. एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से. And I would now request Dr. Avadhish Kumar, sir, the honorable chairperson for this particular session, to kindly honor and facilitate Dr. Shankar S. Sain, sir, from Siliguri. Let's have a huge round of applause for him as well. एक बार शानदार तालियां. Shankar S. Sain, sir, सिलीगुड़ी से हमारे बीच आए हैं और बहुत बहुत स्वागत और अभिनंदन है सर आपका. और अब मैं अनुरोध करूंगी डॉक्टर मृत्युंजय कुमार सिंह सर, जो कि गया से हमारे बीच आए हैं और आज के इस सत्र के वो ऑनरेबल चेयरपर्सन है, मैं उनसे अनुरोध करूंगी कि डॉक्टर पी.के. अग्रवाल सर, जो कि कटरा से हमारे बीच है, उनका सम्मान वो अपने कर कमलों द्वारा संपन्न करें. एक बार शानदार तालियां आनी चाहिए तो डॉक्टर पी.के. अग्रवाल सर. और अब मैं अनुरोध करूंगी हमारे आज के इस सत्र के ऑनरेबल मॉडरेटर डॉक्टर अजीत कुमार सिन्हा सर, जो कि बेगूसराय से हमारे बीच हैं. मैं उनसे अनुरोध करूंगी कि वो हमारे आज के इस सत्र के सभी ऑनरेबल चेयरपर्सन्स को वन बाय वन ऑनर करें. तो सबसे पहले मैं उनसे अनुरोध करूंगी डॉक्टर S.K. गोयनका सर को सम्मानित करने के लिए. एक बार शानदार तालियां आनी चाहिए. डॉक्टर S.K. गोयनका सर is the honorable chairperson for this particular session. I also request our moderator to kindly honor Dr. Avadhish Kumar sir. Once again, I will request all of you to kindly put your hands together for Dr. Avadhish Kumar sir. I will now request our moderator Ajit sir to kindly honor Dr. Mrityunjay Kumar Singh sir. And I will request our moderator to kindly honor our another honorable chairperson, Dr. Mrityunjay Kumar sir. And I would now request Dr. Pramod Kumar Singh sir to kindly come upon the stage and honor our honorable moderator, Dr. Ajit Kumar Sinha sir. एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से. डॉक्टर प्रमोद कुमार सिंह सर अब मंच पे आप देख पा रहे हैं उन्हें, और वो सम्मानित कर रहे हैं हमारे परम आदरणीय मॉडरेटर डॉक्टर अजीत कुमार सिन्हा सर को. एक बार शानदार तालियां सभी लोगों की ओर से. और आप सभी लोगों को पुनः मैं बहुत बहुत धन्यवाद और बहुत सारी शुभकामनाएं देना चाहूंगी। And on this very happy note, we are concluding this session in a formal manner. We are all set to commence our next session, which is going to be the last session of this conference, second day of our conference. And this is the 7th session. And in order to moderate this particular session, I will request Dr. Mrityunjay Kumar Singh, sir, from Gaya. I will request you, sir, to kindly remain on the stage. And I will request our honorable moderator to carry on the further proceedings of this particular session. Thank you so much.
So this is the last session of today, and seeing the number of audience, it gives quite satisfaction. So to chair the session, we have with us Dr. Ravi Shankar Singh from Begusrai. Please come on the desk, sir. Dr. Ravi Shankar Singh and Dr. Shankar Kumar and Dr. Sudhir Chandra Jha, sir. Sir, please join us. And the session will comprise 3 topics. First is remission of diabetes, facts and fads, and that will be covered by Dr. Saibal Guha. Diabetic foot, what physicians should know, by Dr. R.K. Modi, and stress, hyperglycemia and its management by Dr. Devendra Bhushan. So over to chairperson, sir.
We have got a very important topic. As you know, we are talking about remission in type 2 diabetes mellitus. We are talking about reversal of the disease in type 2 mellitus. There are so many factors, definitions associated with this particular thing, with advanced knowledge of diabetes mellitus. And to speak on this highly important topic, the topic which will interest one and all, we have Dr. Saibal Guha, who is the consultant physician, director in the Positive Healthcare Center, Boring Canal Road, Patna. And he has been important speaker and a contributor to medical literature. Over to Saibal Guha to talk on this important subject.
Good evening, respected teachers, seniors, and dear friends. I'm thankful to the Ccdic committee for giving me this opportunity and honor to take in front of my teachers sitting in the front row. Dr. You have to sir, Dr. Chandra and Priyanka sir, Dr. you also. I have been given to talk on the definition of type diabetes. It's a often talk about diabetic, and I will come to the back of that, and we see what the recent updates are. To start with, what have we been taught over the years? We have been taught that type 2 diabetes is chronic, incurable, and progressive disease caused by insulin resistance. There is progressive declining beta cells. You can get that there is blood glucose control over years. And okay, so it's a down decrease where despite all the disease keep increasing, and because the cells are get on deleted and the disease becomes more and more severe. However, the scenario changes and the paradigm that type 2 diabetes is serious versus chronic has gradually changed. The natural use of type 2 dependent on what we get. And then weight which funded diabetes to develop is maintained or allowed to increase, then the disease separately progresses. However, on the contrary, weight loss, which is sufficient to reduce or normalize the intra-organ fat deposit, is achieved or maintained, and non-diabetic glucose control can be established. So, this is the simplistic concept of reversal game from a financial view. Most of the processes involved in insulin resistance, which drives with size that these are reversible, and it's typically makes the disease reversible and curable by changing the dietary habits and physical activity, particularly in the early in the disease process. So there is sort of concept behind the idea of reversibility of diabetes. So for us, the topic of reversibility is one of the definitions, the terminologies. There are three terminologies and they are not interchangeable. First is reversal with originated in the peak cycle hypothesis. It essentially means the process of returning to low diagnosis of diabetes and not to come back again. The second term is remission, which was found in the direct study. It means that the sustained glucose control is not diabetic levels. Without glucose, there will be no impact over a period of time. And the third term is which is not still now available and is served to get avoided. So, that definition is a very interesting study. The scientists who this study, the various six publications, what is the definition of the and it was surprising to see that after studying and we concluded 60 definitions of reversal, of which 9 were unique. So the definition was never defined properly. So that was a problem definition. And out of the 8 in 2021, when we that the repetition is less than 6.5%, or the estimate of 6.5% based on CDM studies. And none of so which are the intervention. So at least 3 months in the absence of treatment. So that was the area definition of revolution. What was the components of revolution? This is concept came from the design hypothesis, the counterpoint study, the direct study, and then the trial, which are the main components of the definition of diabetes. And of course, the diabetes can be the definition can have the diabetes. So the design hypothesis is clearly by this mentioned that and similarly cycle one user cycle and one cycle leads to leading to reduced cycle. So basically the cycle and pancreatic cycle act together in leading to diabetes. This can be found with the so this cycle hypothesis say that even fat leads to diabetes and increases growth. And this leads to and this is on the islands, and that leads to diabetes and insulin resistance. And this is it is not just diabetes well controlled by diet. It is a different entity per se. The negative sound is established a negative by fat and leading to substance and getting fat with period. So this is which out of and very low calorie diet. The third study, which most study that which intervention. This study was done and 252 weeks. And it concluded that the time to around 6 years duration can be reversed by the weight loss evidence structured weight management program delivered in the community setting by doing primary care staff. And also participants for the relationship at least 15 kg of weight loss at the end of 1 year. Although patients in individual groups of diabetes. The left diagram this was had and we had achieved replication part of the complete. So and the diabetes that was predicted predictions. And on this, we are all and we have been deciding on the last few years in the speaker that becomes more independent of modern obesity as well as diabetes. Glycemic improvements are very rapidly often in our days, and glycemic improvements often disease weight loss. Meaning that endocrine responses to responsible and not decreasing glucose. So immediate impact of dialysis are calorie restriction, stomach energy, and ultimately because that's function because as mass sensitivity reduce increase glucose utilization. So these advantages of dialysis surgery, and you will see that the studies of technical dialysis that the improvement because that's function after we apply parts substantial and not changes in weight loss or sensitivity, but they essentially improve the function. So that was the trial that there was reduction in diabetes and through intelligence therapies, and after these trials which came in neighborhood reduction, we are seeing these different diabetes bodies and publications like all of them came up with articles in reduction, like diabetes and confidence. So this is something that no primary diabetes can be reported. However, three clinical validated methods were shown that which can bring remission first and foremost for diabetes surgery, then the middle of diabetes or indicated in diet. However, all good things don't last forever, and that's what happened with this supply of the nutrition. We are seeing this article that the rapid improvement in diabetes is the draft or is the surgery. And this shows for the last time that the in the pre-surgery period versus during the post-surgery period, meaning that the proper and tight diet is more effective in reducing weight loss as compared to surgery. So, what the and all this complications of the complications in the pre-high of the basis and I and there are complications. So the way it goes through and we have to essentially published also as we can see here. So the next letdown was weight loss by diabetes intervention. Weight loss was diabetes intervention was essentially of two types: low calorie diet, low carb diet, or very low carb diet, VLCD. the less than 50 grams of carbon per day can require less than 30 grams of in use in nutritional ketosis also. And we have seen in the various years in the trials that the relationship is proportional to weight loss. Greater the weight loss, greater is the percentage of remission. The patients who have lost more than 15 kg of weight, about 85% were seen to have diabetes remission as compared to patients who have lost lesser weight. However, all the trials with BLC or obesity, like this trial published in Nutrition and Diabetes, and the next one published in taken from the diet study, all of them have shown that whatever the benefit which came down initially, the loss in body weight, again the graph keeps on moving up. So there is, it doesn't stay down, the body weight again starts moving up. Despite the best of efforts, despite continuing with the same therapy, same diet and everything. So there is somewhere a complacency in the body which there is a efforts that are putting in. Similarly, there is a large amount of patient dropout, as you can see. Patients who did not complete, there was a large amount of that. And also the weight loss was initially minus 14.5 kg, and then it gradually maintained, but there is still an upward trend. That is, the weight loss was not very sustained. Again, take out from the diet study. The first bar is from 12 months, second bar is from 24 months, and you can see that the percentage of patients in the remission has come down from 46% at the end of 12 months to 36% at the end of 12 months, meaning that it was not continued, that the remission did not stay as it was when it was achieved. So it could not be sustained. Similarly, here also, the remission, the weight loss could not be sustained, and we see that the weight loss was lesser at the end of longer duration, at the end of the second year, as compared to at the end of the first year. So there was somewhere complacency, somewhere a failure in maintaining the weight loss with the various dietary regimes. And this study, incidence of remission in adults like diabetes and aging study, it showed that we had very low remission in community settings. That was a study which was done in a clinically very mechanical and scientific way. But when this was translated into a community setting and then was tried upon the general patients locally, it was seen that the remission rates were very low, from the tune of 1.47% to 0.07%, meaning that it was practically not occurring in the community. This is a table of the study, and it showed that the partial remission was in 1.4%, complete was only in 0.14%, and prolonged remission was only in 0.07% of patients. So the remission could not be sustained. A recent study has identified that 5 replicable clusters of adult diabetes with different diabetes progression and risk of diabetes complications that are there. The 5 clusters are severe autoimmune diabetes, severe intermittent diabetes, severe intermittent diabetes, mild obesity related and mild age related, and based on these, SIRD, MOD, and MIRD, these are the 3 cohorts of diabetes which can go into remission. So to summarize, remission is not possible in type 1. Remission is often seen after relaxing GDM, stress-induced hypoglycemia, drug-induced hypoglycemia. Who can achieve remission? Are limited subset of diabetes. Less than 6 years of diabetes, better than less than 2 years. Those with good control, those with good insulin secretion, with less visceral fat, those on less anti-diabetic medications, those with good mental health and very motivated. Motivation is the crux of remission. However, there are pitfalls like severe energy restriction, effects on the body in the long term. The long-term health issues could be there by low-calorie diet. Achievement of remission is difficult to maintain long-term weight loss. And finally, adaptation of the body in response to prolonged calorie restriction. Body may shift the energy balance around the relation of weight towards weight gain after weight loss, after prolonged remission. So these are the pitfalls. So what can be the effect on diabetes complications? That's another issue of concern. Even after remission, we are not sure that the classic complications of diabetes, like retinopathy, nephropathy, neuropathy, and enhanced risk of cardiovascular disease, whether they still occur at the same level, or they come down, or they increase. Long-term effects of remission on mortality, cardiovascular events, functional capacity, and quality of life are also not known. So we are not very sure that despite bringing down the remission by VLCD, whether we are doing more harm to the patient or doing good to him. Also, the silent hit would be a possibility of abrupt worsening of various microvascular diseases. Because we have seen that when both glycemic control is there in the patient with retinopathy, and this patient is a rapid reduction of glucose, the retinopathy worsens. So the same could happen when we are putting the patient on strict calorie control. If the patient is having microvascular complications, that will worsen even when we are putting him on a strict control. And obviously, there are various questions. 1 minute. There are various unanswered questions whether the long-term remission can translate into prevention of any further microvascular damage caused by diabetes. We are not sure. We are yet to understand the complex role of diet in the pathogenesis and prevention of diabetes. So that there may be a complex link to it, and the underlying mechanisms of reversal in each therapeutic approach, whether it's by drug or diet or surgery, can have some pathway in common which we still don't know. So these are the answers, but the future is always mathematical. We should tread at the middle path and we should hope for the best. As the cost of diabetes has escalated and the picture of diabetes has increased across the globe, society can no longer afford to ignore the pandemic. So understanding type 2 diabetes remission may become a priority in the future. Many practitioners might choose to promote remission or reversal to patients based on the latest evidence. Because as the current standard of care by the various guidelines don't talk anything about control of diabetes, they only or prevention of diabetes. They only talk about controlling the blood sugar levels. So practitioners might choose to promote remission or reversal to their patients based on the evidence. And future is likely to present a stepwise approach to type 2 diabetes reversal and remission based on the patient's metabolic baseline. And the remission may be seen as a primary, especially for pre-diabetes and newly diagnosed type 2 diabetes patients in the future. Thank you for patiently listening.
Nice elaboration on remission. So if any comment from our chairperson, sir?
Yes, Sabal, thanks for and congratulations for a wonderful talk. One thing, the early intensive treatment, particularly with insulin, can provide remission for at least for some time, maybe a year, is mentioned in literature. Second thing, you are the leading diabetologist and physician of the state. In your practice, how many cases you have seen of remission and reversal? Third question, I will just punch with it. What is, in your opinion, the cause of recurrence, and is there any study to suggest that any intervention that causes this recurrence level to come to the lowest possible level?
The first I believe, was not a question, an observation about insulin, and that is very true. When we give insulin, it brings down the sugar levels, it brings down the glucotoxicity, and that improves the compliance and glucose sensitivity of the beta cells, and the beta cell becomes more sensitive, and we often find remission in very early diabetes, young early diabetics, and that's been advised by the protocols now also. And the second was how many patients I have seen. I'm afraid I haven't seen yet. But there are a few patients who are in remission who could satisfy this criteria, that they have become diabetes, they have been detected with diabetes just a few months back and very mild level of sugar, and they have gone on intensive diet control and exercise regime, and probably they have been off diabetes, off drugs for last 6 or 7 months. But we are yet to see the continuity, how long that continues, it's not very sure. And if we talk about the recurrence part, sir, recurrence, I believe the compliance is the major factor. It's very impractical to follow the dietary regime which is advised by the VLCD diet, having less than 50 grams of carbohydrates per day with that amount of exercise. It's very impractical to sustain. So that was done in a trial, and those patients were motivated and they could do it. But it's very difficult to convince somebody in the community, convince our patients in the community to do that. And probably that is the main reason for recurrence.
That was a wonderful deliberation, and the take-home message is that it is possible, but recurrence is very much there, and we need to evolve something very sustainable which can be continued by the patient for a long period of time. Thank you, Sawal, for a wonderful lecture. Any questions from audience?
Yes, very good evening. I am Dr. Dheeraj Shanjilya. I am CTPS surgeon. Sir, thank you for your wonderful lecture. You are very known and the very earliest physician in the Bihar who developed the critical care. I'm totally agree with you that I believe it's better. And if it is not more than 6 years old. But being an organist, I might be little bit from you while you systems. Now, what we teach, as far as concerned, if somebody is able to develop the diabetes, then also, as far as concerned, what we say that once you are diabetic or you are diabetic, I will say if you are and we have to reduce to 5.8. Then also, what we have to make that is effective. So, there are we can use the but if you use the ordinary antigens, even one of that after the it is the same as the diabetic patient that are not with diabetes. So, but the thank you. That's really and all the more hands of being a surgeon, you are delving into this and talking about this. Thank you. Very good point. What you point out. I fully agree with you. That once very true. You're genetically tuned to be diabetic because that's why you become a diabetic. So even if you control the sugar levels, you are more prone to develop it again in future as compared to a non-diabetic person. So and actually your metabolic syndrome, if it's there, so your lipids are normal, you are more able to develop vessel adiposity. So all other factors are already there. But having said that, what methodologies are we are following has been advised that bariatric surgery or BCD diet. Both of them, they not only reduce the body carbohydrate content, the body weight, they also reduce visceral adiposity. So they reduce the risk of diabetes as well as metabolic syndrome, but they don't totally negate it. That's for sure. That's all that genetic risk will always be there. You are very true in that. Thank you. Thank you. Sir.
We need perhaps be aware that this is the time to get an insulin resistance rather than go for just glucose control.
Right.
To take care of the metabolic syndrome. And in this regard, I would like to highlight another area of the neglected area that is exercise.
Yes.
You know what is the recommendation by ADA for the exercise? 5 days a week, there should be aerobic exercise total 150 minutes. And there should not be a gap of more than 1 day. And that should be supplemented by resistance exercise. Of all the group of muscles on the alternate day. And thirdly, you can chair for more than 30 minutes. Every 30 minutes of sedentary habit should be punctuated by 3 minutes of aerobic exercise. So this is the definition of proper exercise. Maybe we are not able to highlight, and maybe we are not able to motivate ourselves and our population for that. And maybe that is one of the causes for this.
Right. Probably the critical aspects. One is exercise, other is on which you relate the diet. And especially the fasting part, which has been there in all the civilizations, all the genres, all the religions. The concept of fasting has been there for centuries, but probably we are missing it out somewhere.
Thank you, Dr. Guma, sir. Thanks for excellent elaboration on the remission with the help of diet and all, and with the exercise also. And there's one thing which I would like to add, that diet control is quite cumbersome, quite stressful. So patient must be told to go for a cheat meal every 15 days or so.
That is.
Thanks a lot.
Thank you.
Okay, thank you, Dr. Sawal.
Thank you.
Thank you. So the next speaker is Dr. R.K. Modi, and he will talk on diabetic foot, what physician should know. So chairperson kindly introduce the topic and the speaker.
Hello. Now I invite Dr. R.K. Modi from Purnia. He will We will talk on diabetic food. What physicians should know, what physicians should know.
Dr. R.K. Modi, he will talk on diabetic food, what physicians should know. I respect Dr. Modi to please come on the dais.
Yeah. Thank you. This is the next slide. This is the next slide. Yeah. Touch it. At our outset, I must thankful to the organizers for giving me this great opportunity. I pay my regard to all the respected teachers sitting here, all delegates for sitting in the last section of diabetes. What is diabetes? I'm not going in detailed definition of diabetes. It is a chronic metabolic disorder affecting nerves, eyes, kidney, blood vessels, and heart. So, diabetic foot is the result of either neuropathy, vasculopathy, or its combination. I must add one more category, that is ignoropathy. So, if ignoropathy is being mixed with neuropathy and vasculopathy, it will result in a diabetic foot, which is responsible for major problem in India. It has become a matter of concern because it is a major commodity and quantity, and it creates a great economic burden. Let us see the magnitude of the problem. Inadequate management of diabetic foot disease can end in a very tragic and amputation of the limb. It is a common source of non-traumatic amputation of the limb. About 70% of amputations are due to diabetes itself. In every 30 seconds, one limb is amputated somewhere in the body, and ADA has indicated that 50% of limb with foot ulcer can be saved if both healthcare provider and taking fulfill their respective responsibility. So we are gathered here to fulfill our responsibilities. When we talk about the spectrum of complications, it includes fetal diabetes to chronic osteomyelitis and gangrene necessitating the lower limb amputation. Let us look at the prevalence and the status. The global prevalence ranges from 1.5 to 16.6%, and in India, the prevalence is 11.6%. Important risk factors are smoking, diabetic peripheral neuropathy with loss of protective sensation, peripheral artery disease, foot deformity, careless or horn, union, hamartosis, sharp foot, history of diabetic foot ulcer or amputation, foot glycemic control, retinopathy, nephropathy, visible impairment, and hormones, different walking, which is very common in India. Food is a great mechanical marvel. It has got 26 bones, 29 joints, and 42 ligaments. It has got a very sensitive and protective skin blanket, excellent nerve supply, great vascularity, and rich collaterals. Why we have diabetic foot disease? And why we don't have diabetic eye disease? When we see the slide, we can find that we have defined the vital posture or direct posture from a tetrapod. During the process of evaluation, where the weight was on the 4 limbs, but now the weight is only on the 2 limbs, and the next factor is that the distance from the eyes to the feet is the farthest, and this is another reason that we have diabetic foot in the body and non-diabetic hand disease. Little bit in the spectrum, we have subjective complaints and objective signs like dry skin, numbness, dermatitis of the West states, little cell and bullying, callousy and more, foot deformity, foot ulcer, diabetic gangrene, and osteopathy. Why? How are we to process food? There is involvement of
small fiber neuropathy as well as large fiber neuropathy. There is more involvement which is characterized by weakness and sensitivity of muscle, grounding of toes, soft toes. There is conflict involvement which is characterized by rise reduce blood supply, and increase game resorption. And therefore, there is responsibility which is characterized by reduce oxidation in the peripheral artery, resulting in ischemia. So this is the slide showing the different autonomic neuropathy, sensitive neuropathy, water neuropathy, which is accompanied by atherosclerosis, giving rise to peripheral artery disease, which is characterized by cold and pain food. Sensory neuropathy is characterized by insensitive and deformed mood, and autonomic dysfunction is characterized by hot and dirty food. It is not necessary at all to create diabetes for common, but it is always neuroischemic because ischemia is one of the important factors giving rise to neuropathy. Also, neuropathy is more common. 2023, it was the position statement up to 50% of diabetic entirely. And it is not recognized food care not implemented. There is talking injuries, ulcer and amputation is embraced. There is no specific treatment for reversal of underlying diabetic retinopathy or neuronal loss. Better control in the form of clinical and hypertension will or retard the process of this food function. So diabetes food is fatal because of poor immunity, because of abnormal inflammatory pathway, peripheral neuropathy, poor immunosystem inflammatory response, and of course hypoxia. Now let's see how a diabetic food develops. We can just compare with a non-diabetic food. In a non-diabetic food, repetitive friction or repetitive stress gives pain, inflammation, and this pain goes to the pain center, and there is adequate gate modification and the process of healing and leading to real weakness. But let's see what happens in the diabetic food. There is repetitive stress, repetitive friction. There is inflammation, but no pain. Very sad. There is no pain. No response from brain, and there is continuous use, non-healing, and finally the result is a foot ulcer. Now, these are a few common examples that I gathered from my clinic of repetitive satisfaction. The repetitive satisfaction or stress due to malfunction and public exposure are only responsible or important for lesion. We can see here the capacity which has developed from body components. We can see the friction that has been developed by a here is the right lateral activities due to the public exposure. What I mean to say, all these things are preventable if we have pinpointed the reason. And if you have given advice that the person or patient for going to leave down on namaz or doing a positive exercise, they should use the soft matter over the body cameras and it can do such leaks there. Now, this is another diabetic food showing fungal infection, wasting of muscles and growing of toes, and that is complete osteomyelitis and it is destruction of the crystal apparatus and all due to the ulcer forms present in the surface of first ready to go. This is slide showing a deformed food. This is the charcoal food. And here we can see the difference. We see the normal food, we can see the arch. The arch in the normal food is concave. But in the charcoal food, it is convex. The arch has convex, resulting in the abnormal shape of the food, abnormal weighting, and the colonopathy and ulcer in the mid food. So, ultimate biomechanics in diabetic food. The whole problem of neuropathic is really one of the academics and not of medicine. Now, If you look for diabetic foot ulcer, there is 15 to 25% of the software looking at foot ulcer in lifetime. Common is like in four, also developed as types of hypertension, continuous patient causing schizophrenia, limited joint mobility is another contributing factor, bony deformity and callus are the marker of elevated pressure. There are few rules, practical rules of identification and diabetic foot ulcer. 85% of the amputation can be resuscitated by diabetic foot ulcer. 50% of amputation are transfemoral and transfibular. 50% of patients will have second amputation in less than 5 years. 50% of the patient die in 5 years. For diabetic foot ulcer, 50% of foot ulcer will convert into osteomyelitis and 50% of foot ulcer will result in an amputation. So, how we examine inspection, palpation, footwear examination is very important. Neuropathic detection by 10 gram nylon monofilament, 128 Hz tunic fork, biochemistry, vasculopathy can be detected by simple palpation of dorsalis pedis artery and ABI measurement by vascular Doppler. So, how to detect neuropathy? For diagnosing small fiber function, we need only pinprick and temperature sensation. We have to only examine temperature, whether patient can feel it or not. For large fiber function, we can examine lower extremity reflexes, ankle jerk, and vibration perception. And 10 gram monofilament is used for that. For detecting protective sensation, we use 10 gram monofilament. But what you need actually, you need your will, your desire, your commitment to diagnose diabetic neuropathy. And you need 2 minutes time, because I know with spin cotton and a twinning fork and 10 gram monofilament, every clinic is having. Only you need 2 minutes time and your devotion to detect neuropathy so that we can save fate of the diabetic patient. Now, there are international working group on diabetes. They have stratified different grades of ulcer, very low, low, moderate, and high. High risk grade is characterized by loss of peripheral sensation, protective sensation, or peripheral artery disease. And there may be history of previous foot ulcer, lower extremity amputation, which may be minor or major, and end stage renal disease. So those foot should be examined once every 1 to 3 months. There is another classification given by Wagner's. They have described different 5 grades, 0, 1, 2, 3, 4, 5, or 0 grade is intact skin, grade 1 is superficial, grade 2, 3, 4, 5 is deep. The ulcers, osteomyelitis, gangrene or gangrene of entire foot, these should be referred to the surgeon with the help of physician to control metabolic factors. So examination of foot, it is never complete if you don't examine the footwear, and you should know the quality of good diabetic footwear or good diabetic footwear, which is in the lower side. It should have a right rillet outsole, a soft sole, insole, which is made up of microcellular rubber. It should have a roomy toe box, wide mouth, so it can give extra depth of shoe with a counter. These are the features of good diabetic footwear. And here we can see few preventive footwears. Now, few practical tips that they should cut their nail in straight. And these are the point of high pressure area. We can see in the red areas, which shown the planters red are the point of high pressure area. And these are those areas where we can, the patient can develop ulcer because of the more weight bearing. Now coming to the management part, which is the last part, it is a teamwork, multidisciplinary approach is required. Physician, diabetologist has a key role to play. Other members of the team are surgeon, nutritionist, diabetic nurse, foot care worker, diabetic educator, diabetic cobbler, all are important for salvaging a diabetic foot. Proper work of diabetic patient is essential to establish neuropathy, vasculopathy, or both. Tight metabolic control is an essential factor. Principles of management are 4: good and tight metabolic control, appropriate use of antibiotic, extensive debridement
it is done by a surgeon, and offloading, which can be suggested by physician as well as surgeon. Purpose of metabolic control is to prevention of hyperglycemia, ketoacidosis, hyperosmolar coma, dehydration, and success and promotion of normoglycemia, control of infection, fast healing, and attainment of normal productive life. And this can be achieved by prompt diagnosis, timely intensification of diabetes control by insulin, short-acting insulin is preferred, frequent monitoring is required, and we must know the target blood sugar level. It is 140 to 180 milligram in hospital setting, and in perioperative period, it would be 80 to 180 milligram. Administration should be subcutaneous or infusion may be required as per the condition. OAD are not preferable in period of stress. So we must classify the diabetic foot, whether it is non-limb threatening, or life-threatening. Few features of life-threatening foot is presence of infection, metabolic instability, and presence of systemic toxicity, which is characterized by fever, chills, tachycardia, hypotension, hyperglycemia, confusion, acidosis, and azotemia. We know the minor problem becomes major and life-threatening if diabetes is not cared early. So in case of diabetic foot disease, a non-limb threatening condition become limb threatening, and if not cared, it can become life-threatening. Non-limb threatening conditions like Ccdsicon, dermatophytosis of web space, deformities like hallux valgus, hamartos, fissures and crack, hypertrophic bursitis, it all can be managed in outpatient basis by giving proper advice regarding foot care and footwear. Minor OPD procedures for callus and corn removal can be done. Appropriate use of antifungal drugs for dermatophytosis, moisturizing lotion for cracks and fissure, and advice regarding customized preventive footwear for foot with structural deformity and foot at risk, that is foot with loss of protective sensations. If mild infection is present, antibiotic like moxifloxacin, ceftonir, linezolid, cephalexin, azithromycin can be used. Life-threatening and limb-threatening diabetic foot condition needs indoor admission and help of surgeon for proper management. So identification of such condition is important for early referral. But before sending a patient to a surgeon, a physician must talk to surgeon and discuss the modality of management regarding correction of dehydration by appropriate intravenous fluid, insulin infusion for correction of hyperglycemia, selection of empirical antibiotic in consideration to the renal status before the result of culture sensitivity comes. In limb-threatening conditions, few combination we use are cefoperazone, sulbactam, plus metronidazole, moxifloxacin plus metronidazole. For life-threatening condition, few empirical combinations we use, it's piperacillin tazobactam plus amikacin, clindamycin plus amikacin. A physician must discuss with the surgeon that the best dressing material for diabetic foot is normal saline only. Use of Savlon, betadine, hydrogen peroxide, eosol is not suitable for diabetic wound because they have direct cytotoxic effect or to the fibroblast and keratinocytes. They can make the condition worse. Use of topical antibiotic is good for keeping the wound moist because moist environment is ideal for healing diabetic wound. Always, always remember the final choice of antibiotic depends on the results of culture sensitivity. Clindamycin, azithromycin, moxifloxacin can be safely used in patient with impaired renal function, but for rest mentioned antibiotic, dose adjustment is necessary. Offloading devices are very important. These are few crutches, shoe with a hinge. These all are offloading devices. This is total contact scars, roll and TCC system, removable boot, crow boot, ortho wedge, post-op shoes, all are offloading, and offloading is very important for proper healing of ulcer. These are the shoes which anterior wedge for ulcer, which is placed in the anterior foot. This is posterior wedge down. That is ulcer situated in the posterior hind foot, and that is rocker bottom for the redistribution of blood pressure, and it is useful in certain conditions. So this we can give this type of leaflet to our patient, and we can educate, because education is part and parcel for the prevention of a diabetic foot. And lastly, to conclude, prevention is the first and the last weapon for the management of diabetic foot. A new diabetic patient, with his first interaction with the physician or diabetologist, is being instructed about foot care. That is a preventive strategy we adopt. And even a serious complication occurs and ends in very tragic amputation of a limb, he is again instructed to take care of unaffected remaining limb and care of the stump. So the disease begins with prevention and ends in prevention. So must touch feet of diabetic patient, he will give you blessing and spend 2 minutes only. And this is my last slide. Journey begins with prevention and ends in prevention. Thank you very much, sir, for your patience listening.
Thank you, sir. Thank you for such an elaborate talk on this overlooked issue. So the nuts in nutshell, what I have concluded from your talk is that always examine the foot in diabetic patient. And if any comments from our chairperson, sir.
I congratulate you, sir, for the excellent elaborative discussion on diabetic foot treatment, which you have already emphasized in your slides. But I would like to again speak it out that antibiotics have a empirical role in the treatment of diabetic foot. It must be, the pus culture must be done. If there is any bacteria grown in that, then only that antibiotic should be given. The crux of the treatment is the dressing. The proper dressing is required in these cases. Excellent presentation, sir. Congratulations.
Thank you very much, sir. Thank you.
Ravi, excellent talk. Message is clear. Diabetes is the most important cause of amputation arising out of peripheral vascular disease. Unfortunately, in India, feet is the most neglected part. Barefoot walking is there. Even in the parties, people will come attired in suit and will be wearing a chappal, though he is a known diabetic for some years. So message is to take care of feet. Wonderful lecture.
Thank you, sir. Thank you. Thank you.
It is on stress, hyperglycemia and its management, and it will be delivered by Dr. Divendu Bhushan from Patna, AIIMS.
It is very common to get cases in our day-to-day practice where a normal glycemic person, a non-diabetic person comes to us, and when there is a stress, infection, surgery, viral infection, corona, something like that, and then the blood glucose level becomes more than 180. That is a stress hyperglycemia. And if they are not properly controlled, they have got negative effect on insulin resistance, and so many complications are there. To talk on this subject, we have got Dr. Divendu Bhushan, Associate Professor and Head, Department of Emergency Medicine, AIIMS Patna, who has got more than 35 publications in national, international journals, and he is part of many multi-central trials. Over to you, Dr. Divendu.
Thank you, sir. First of all, thank you to all the organizers, Dr. A.N. Rai, sir, Dr. A.K. Virmani, sir, Dr. Ashik, Dr. Mrityunjay, Dr. Sumit, and all the organizing team who gave me opportunity to come here in Begusarai and share my thoughts about the stress-induced hyperglycemia. So, stress-induced hyperglycemia is a entity where the person is not a diabetic and it behaves, and the clinician got confused between what is the patient is a diabetic or not, and in the due course, they come to see the real scenario. So my talk is I will talk on following topics like basics of the stress response, definition of stress-induced hyperglycemia, pathophysiology,
clinical presentation, its impact, management, prognosis, and few cases. So basics of stress. So when a stress come to our life in the form of physical stress or of psychological stress, we have two responses. One is the fast response, which is by the sympathetic system, and other is the slow response, which occur by the hypothalamic pituitary axis. And that fast response occur mostly by the noradrenaline, norepinephrine, or epinephrine. So what these epinephrine and norepinephrine do exactly? They act on the alpha receptors and the beta receptor, as we already know. There are two types of alpha receptor, alpha 1, alpha 2, and there are three types of beta receptors. I have enumerated the actions and the location of those receptors, and these interplay depend upon our stress response. So what major thing occurs while a person is in stress? What occurs in the muscles? It increases the glycogenolysis. So the glycogen breakdown occurs, and it provides the readily energy for muscle contraction, and it is stimulated by the adrenaline. In the liver, again the glycogenolysis occurs, which produces the sugar, it produces the glucose, and it provides the energy. It is stimulated by the adrenal glucagon and inhibited by the insulin. In the pancreas, there is an increase in the glucagon secretion, and there is an inhibition of the insulin secretion. So how this occur? It is by the, we can go in the biochemistry book. We have to go through this, what are the stimulators and the inhibitors of insulin secretion, and what are the stimulators and the inhibitors of the glucagon. The glucagon is the major hormone which governs our stress response regarding the glucose control. So we can see that stimulator of the insulin are glucose, and inhibitor is the starvation or hypoglycemia. The opposite occur with the glucagon. In the glucagon is stimulated by the exercise, cortisol, infections, other stresses, beta adrenergic stimulators, theophylline, and it is inhibited by the insulin, ketones, free fatty acids, and somatostatin, and even glucose. So now the definition. So how we define stress-induced hyperglycemia? It is defined by any random blood glucose level of more than 140 mg/%, and patient must be suffering from some critical disease. The pathophysiology behind this is depend upon the pancreatic beta cell dysfunction and increased glucagon level. The major portion of the stress-induced hyperglycemia is depend upon, again, on the norepinephrine and epinephrine and glucagon. So pro-insulin level increases. There is a rise of glucagon level of more than 4 to 5 times. The person, as he is ill, he eat less, and there is a high sympathetic activity, and it decreases the insulin secretion. Most of the inhibitory effect of insulin on glucagon secretion is mediated by the paracrine effect within the pancreatic cells. So insulin supraphysiological, if we give the insulin supraphysiological dose, it does not decrease the glucagon secretion, as it probably not sufficient to reach normal glycemic value in hyperglucagonemic state in the SIH. So we can understand that when the person is there in the stress-induced hyperglycemia, that glucagon level is high, and we cannot negate it by the giving more and more insulin. So second is sympathetic nervous system. Epinephrine directly increases the glucagon release. It increases the insulin resistance. It mobilizes the free fatty acid from adipose tissue, oxidized by the skeletal muscles, and impair the glucose utilization. It increases hepatic genolysis. At mitochondrial level, there is a decrease in the ATP production and oxygen consumption. It increases the free radical production, that further increasing the insulin resistance. The third is renin-angiotensin system. It stimulates the angiotensin 2. Stimulation of the angiotensin 2 is associated with the insulin resistance. And it is seen that international studies showed that ACE inhibitor and ARB, the use of ACE inhibitor and ARB reduces the incidence of diabetes mellitus. The overactivity of RAS system in cardiovascular disease is likely to impair the insulin signaling and contribute to the insulin resistance that we often see in the patients of acute coronary syndromes. So the combination of increased counter-regulatory hormones and pro-inflammatory cytokines, insulin resistance, and increased gluconeogenesis, all these contribute to the stress-induced hyperglycemia. The factors, there are certain factors related to the treatment like use of steroid, vasoactive agents, or TPN. These are also the factors which can cause increase in the glucose level. So the summary of the pathophysiology, the stress-induced hyperglycemia depend upon the cytokines and hepatokines like TNF-alpha, IL-6 and IL-1, hormones like glucagon, growth hormone, cortisol and catecholamines, and these cytokines like IL-6 and TNF-alpha and IL-1. So what is the clinical impact of stress-induced hyperglycemia? So stress can be anything like physical or psychological. We can see such type of situation in the OPD, IPD, ICU or emergencies. When we encounter such patients in the OPD, it is the time taking period. So if we think that the person is not a diabetic previously and it is due to the illness, suppose the person, as Dr. Jha has already said, somebody is suffering from URI or LRTI like COVID and he is having hyperglycemia. So it is the time will tell whether the person is actually the hyper diabetic or not. In the ICU, it is associated with a poor outcome and long stay. So transient increase in the blood sugar work as a rescuer from the illness as it increases the glucose level, but the persistent hyperglycemia leads to changes in various preventive mechanisms like macrophage and neutrophil activity, complement fixation, endothelial dysfunction, alteration in the vascular smooth muscle tone, and there is an abnormality in the coagulation pathway. There are various studies which shows poor outcome of the acute coronary syndromes in stress-induced hyperglycemic patients, and there are chances of more of the arrhythmias, heart failure, and cardiogenic shock in persons who have hyperglycemia along with ACS. Acute stroke also has poor prognosis in the form of recurrence, hemorrhagic transformation, and mortality. The study by the Plummer et al. Shows that over 18 years in a retrospective study, they found that there is a 4.8% chance of developing diabetes after critical illness in non-diabetic patients. So somebody who has developed stress-induced hyperglycemia, in the long term, he has more and more chances of developing the diabetes. What about the acute and the chronic complications of in the SIH? When I go through the Google, there is only one case report in a neonate where the baby presented with DK, and that was retrospectively diagnosed to be as a stress-induced hyperglycemia. Only single case report, and there is no study that was done for the chronic complications in a person who has stress-induced hyperglycemia. So in the management, what is our target? Target are simple as we keep there in the targets of the diabetic control. The fasting should be less than 130, postprandial should be less than 200, random should be less than 200, and in ICU, we have to keep between the 140 to 180, neither less than 140 and nor more than 180, because hypoglycemia, the sugar level, more the hypoglycemia, it is associated with the worse prognosis. So how can we control it? So it depends. What is the situation actually? It depends upon person to person. I will deal with few clinical scenarios. So diet. So if some person is there in the IPD and he is suffering from LRTI, he is taking meals. So what we can do, we can just advise a diabetic diet. And over the time, that sugar can be controlled and we can check it. In the admitted patient, we can give regular insulin or basal insulin if it is indicated. In basal insulin and the insulins that regular insulin or short acting insulins can be given in IV or the subcutaneous form wherever it is required. In the COVID, in the mild to moderate case, the use of metformin and DPP-4 inhibitor is recommended by the ICMR also. And we can check the blood glucose after 2 to 4 weeks after the stress ends. How is the prognosis? It is poor in comparison to the normoglycemic patients. Fasting blood glucose, postprandial and HbA1c is recommended to do annually if somebody develops stress-induced hyperglycemia. So this is the first clinical scenario. If a 45-year-old male patient presented to the ER with a chest pain since 12 hours and his blood pressure is 170/90, pulse is 64 and RBS is 450. So now what we ECG reveals it is inferior valve MI. So what we will do? So we will do first, as it is more than 300, we will do the urine ketones, ABG and HbA1c. We can check the HbA1c at this time, that whether the person is undiagnosed diabetic or a stress-induced hyperglycemia. And how can we treat him? We can treat him because he is a person who is suffering from ACS. We can give him insulin infusion and our target is 140 to 180. Now the second patient, this 45-year-old lady with BMI of 35, planned for lab chole, found to have fasting blood glucose of 180 and postprandial of 340. She is a OPD patient. It is a common scenario. HbA1c found to be 6.2. Now what we will do? We have to check her menstrual history. Is there any history of GDM? Is there any delivery of a baby who was 4.5 kg, more than 4.5 kg body weight? We have to, in the examination, we have to look for the blood pressure and signs of insulin resistance. Investigation, what we can add a lipid profile and a thyroid function test. And how will we treat it? Weight reduction with diabetic diet. And as the BMI is quite high, it is morbid obesity, that we can add metformin. If with the diet control, this sugar is not getting controlled, then we can add metformin, and on the top of it, DPP-4 inhibitors, we can add on this. Now the third case scenario is a 60-year-old lady, known case of rheumatoid arthritis on DMRDs and steroid, prednisolone 10 mg per day, developed recurrent UTI. On investigation, her fasting blood glucose is 150 mg%, postprandial is 240, and HbA1c is 6. Now, what should we do? Should we stop steroid advertently? It is a tough call. So steroid was stopped and sugar came to be 135, not much control, but she's complaining of unbearable pain in the joints. Now we have to again start. Next option is once weekly. We will modify the dose of steroid or we can add biologicals. So now the last case, a patient presented with fever of 4 days, shortness of breath and cough 3 days. SpO2 is 90% at room air and RBS was 245. This scenario we all of us must have seen in the COVID era. Now HbA1c is 6.2 and RT-PCR for COVID is positive. Steroids to be given. We know that as the SpO2 is 90% at room air, we have to give steroid. And to start with, we can give HIR if the person is ready to take it or admitted, or we can start metformin or DPP-4 inhibitor along with this. So these are the few case scenarios. And the last, I would like to say that the stress in our life, give the wings to the stress and let it be fly away. Like this. Thank you.
Thank you, Dr. Devendra, for nicely explaining the things. One thing in case number 3, your patient is rheumatoid arthritis. Your patient is rheumatoid arthritis, and he is taking 10 mg steroid, 10 mg prednisolone for long. So, will you stop immediately?
Just it is a dilemma for all the physicians. You should we stop it, or we should add something anti-diabetic?
No, steroid should not be stopped immediately. It should be tapered off.
It can be tapered off.
Yes, it should be tapered off. If patient is taking a steroid for long, then it should be tapered off. It should not be stopped immediately. This is my point. Okay, thank you.
It was excellent presentation, sir. There is a small question. How tight should be the sugar control in an ICU scenario? Most of them were the intensive care scenario. So how tight it should be?
In the
Sugar control.
In the intensive care, sir.
Pardon?
In the intensive care.
Pardon, sir?
The sugar control in intensive care or in the general?
Sugar control, the level of the sugar control, how tight it should be? What should be the
He is asking that you are asking this in the form of intensive care. Patient is in intensive care, and what should be the sugar control?
Sir, the topic is stress hyperglycemia.
That's why he has already mentioned 140 to 80 in one of his slides.
140 to 180. Okay,
180,
fine.
His question was level, which you have emphasized time and again. It should be between 140 and 180. Hyperglycemia is wrong, but hypoglycemia is more dangerous, and that is the main concern.
Thank you, sir.
Any questions from the audience? Okay. If there are no questions, we'll now moderator to close the session, please.
Session. Thank you.
Thank you so much. I will request all of you to kindly remain with us. And now we are going to have the felicitation program once again. So I would request the Honorable Chairperson of this particular session, Dr. Ravi Shankar Singh, sir, to kindly come forward and honor the speaker for this particular session, Dr. Saibal Guha, sir, from Patna. Saibal Guha, sir, if you are present with us at this very moment, I will request you to kindly come upon the stage. So I presume that he is not present with us at this very moment. So I would now like to take the next name, the name of our next speaker, who is Dr. R.K. Modi, sir. And in order to honor him, I will request Dr. Shankar Kumar, sir, from Begusai to kindly come forward and honor Dr. R.K. Modi, sir, from Purnia. Dr. R.K. Modi, sir. I will request Dr. Shankar Kumar, sir, to kindly honor Dr. R.K. Modi, sir. Let's have a huge round of applause for Dr. R.K. Modi as well, Dr. Shankar Kumar, sir. I will now request Dr. Sudhir Chandra Jha, sir, to kindly honor another very proficient speaker of this particular session, who is Dr. Divendu Bhushan, sir, from Patna. And let's have a huge round of applause for him. A very eloquent, well-informed speaker, Dr. Divendu Bhushan, sir, who is sharing his thoughts and experiences and research with all of us. Thank you so much to each one of you, to all the speakers of this particular session. I would now request the honorable moderator of this particular session, Dr. Mrityunjay Kumar Singh, sir, to kindly come forward and honor all the honorable chairpersons of this particular session. First of all, I will request Mrityunjay, sir, to kindly honor Dr. Ravi Shankar Singh, sir, from Begusai. Let's have a huge round of applause. Dr. Mrityunjay is now going to honor Dr. Ravi Shankar Singh, sir, from Begusai, who is the honorable chairperson of this particular session. And let's give it up for him. एक बार शानदार तालियां डॉक्टर रवि शंकर जी, जो कि हमारे इस सत्र के माननीय अध्यक्ष के रूप में हमारे बीच उपस्थित थे। और अब मैं एक बार फिर से डॉक्टर मृत्युंजय से अनुरोध करूंगी कि वो हमारे बीच उपस्थित हमारे ऑनरेबल चेयरपर्सन डॉक्टर शंकर कुमार सर, जो कि बेगूसराय से ही हमारे बीच हैं, उन्हें भी सम्मानित करें अपने कर कमलों द्वारा। एक बार शानदार तालियां सभी लोगों की ओर से। और पुनः मैं डॉक्टर मृत्युंजय कुमार सिंह जी से अनुरोध करूंगी कि वो हमारे बीच उपस्थित डॉक्टर सुधीर चंद्र झा सर, जो कि हमारे इस सेशन के ऑनरेबल चेयरपर्सन के रूप में उपस्थित थे, उन्हें भी सम्मानित करें अपने कर कमलों द्वारा। और इसी के साथ साथ अब मैं अनुरोध करूंगी डॉक्टर सुमित कुमार वर्मा सर कि वो हमारे बीच आगे आए। एक बार शानदार तालियां डॉक्टर सुमित कुमार वर्मा सर। आप देख पा रहे हैं हमारे ऑनरेबल मॉडरेटर डॉक्टर मृत्युंजय कुमार सिंह सर का सम्मान करते हुए आप सभी देख पा रहे हैं उन्हें। अत्यंत ही अद्भुत व मनमोहक क्षण है ये हम सभी लोगों के लिए। इतने सारे प्रेरणादायक और प्रभावशाली व्यक्तित्वों को हम एक साथ मंच पे देख सकते हैं, मंच साझा करते हुए। ये अपने आप में एक बहुत ही सुखमय पल है हम सभी लोगों के लिए। और इसी के साथ हम लोग आज के सत्र के, यह हमारा अंतिम सत्र था आज के इस सम्मेलन का, आज के इस कॉन्फ्रेंस का। पर अब हम लोग अपने इस आयोजन के समापन की ओर अग्रसर नहीं होने, अभी बहुत कुछ होने वाला है। तो मैं आप लोगों से अनुरोध करूंगी कि हमारे बीच बने रहें और मंच पे जितने भी आदरणीय अतिथिगण हैं, आप सभी लोगों को पुनः मैं धन्यवाद कहना चाहूंगी। और आप सभी से अनुरोध है कि आप लोग थोड़ी देर के लिए अपने अपने जगहों पर विराजमान हो जाएं। और अब हम लोग जीवी मीटिंग की ओर अग्रसर होने वाले हैं। और जीवी मीटिंग के लिए लगभग सभी तैयारियां की जा चुकी हैं। Almost all the arrangements have already been done for the GV meeting, and we are going to head towards the GV meeting. So once again, a very big thanks to each one of you.
Yeah.
Good evening, sir. It will take around 7 to 10 minutes to arrange the dais. By the time we will conduct the annual GB with permission of the chairman of the state chapter, Dr. P.K. Singh, sir. May I request dignitaries to please come forward. First of all, Dr. Professor A and I, sir, founder president. Dr. P.K. Singh, sir, chairman Bihar and Jharkhand chapter. Dr. Umesh Khan, sir, chairman elect Bihar and Jharkhand chapter. Dr. Mrityunjay Kumar Singh, secretary CCDSI national. Dr. Ajit Kumar Sinha, chairman scientific committee. Sumit Kumar Verma, immediate past chairman. Dr. K.K. Lohani, sir, please come on the front. May I seek permission of chairman of the state chapter, Dr. P.K. Singh, sir, to start the GBM. Thank you, sir. The first agenda is apology, if any. There is no apology. Second one is condolences. No informed condolence. So yeah, good for us, sir. The third one is confirmation of proceeding of last AGM. So next one, address by current chairman, Dr. P.K. Singh, sir.
Dr. Dr. B.B. Thakur, sir, Chief Guest, Dr. S.K. Lal, sir, Dr. Kamlesh Sivalo, sir, Dr. R. Jha, sir, यहाँ पर बैठे हुए डॉक्टर लोहानी, डॉक्टर खान, डॉक्टर अजीत कुमार सिन्हा। हम लोगों का ऑर्गेनाइजेशन जैसा कि आप लोगों को महसूस हो रहा होगा, सही दिशा में जा रहा है और ये हमारे जो सीनियर्स हैं उनके दिशा निर्देश में चल रहा है, इसलिए अच्छा जा रहा है और हम लोगों को सीखने की आवश्यकता है। इसको कैसे और आगे बढ़ा सकें, इसको नेशनल हॉरिजन पर एक चमकता हुआ सितारा कैसे बना सकते हैं, इस विषय में हम लोग को सोचना है और उस तरह की स्ट्रेटेजी तय करनी है। और जो भी लोग यहाँ पर इतना एक्टिवली भाग लिए हैं, सुमित कुमार वर्मा जी, अजीत कुमार सिन्हा जी और बहुत सारे यहाँ की जो टीम, वो लोग को हम लोग काफी अप्रिशिएट करते हैं और इसी के साथ हम अपनी बात खत्म करते हैं। धन्यवाद।
Thank you. The next agenda is annual report by the secretary. I have prepared the secretary report and I will present it during the inauguration. The next agenda is accounts by the treasurer. Unfortunately, our treasurer, Dr. R.S.P. Singh sir, is not here, but he has communicated his best wishes. And on behalf of him, I am presenting the accounts that there is no transaction for a state chapter during this financial year. So in this heading, there is no transaction.
बहुत स्ट्रिक्ट में जब चाय भी पीने को अपने पॉकेट से खिला देगा, लेकिन सर का पैसा कहीं नहीं।
The next agenda is announcement of office bearers for the next session. Under the able guidance of current chairman, Dr. P.K. Singh sir, the last executive body expressed desire that since we are the first state and head office is located in our state, so we will give this responsibility of selecting the office bearer for the next session to the high powered core committee of the central team located at headquarter Gaya. And from there, I got the recommendation. I am just sharing the names of the office bearer for the next session. Now, for the year 2023-24, the chairman will be Dr. Umesh Khan sir from Jamshedpur. Treasurer will remain same, Dr. R.S.P. Singh sir, Gaya head office. Secretary, myself, Dr. Abhishek Kumar, because we have 3 years secretaryship and this is my 3rd year. Chairman elect Dr. R.K. Modi from Purnia. We elect 3 vice chairmen. The first vice chairman is Dr. B.K. Singh, Aurangabad. The second vice chairman, Dr. Gagan Gunjan, Ranchi. Third vice chairman, Dr. Raj Kamal Chaudhary, Bhagalpur. For this academic year 2023-24, chairman scientific committee will be Dr. A.K. Arya. Sir is already here. The joint secretaries, Dr. Neeraj Kumar from Gaya, and Neeraj is already here, and Dr. Rajiv Jha from Patna. The executive committee members are Dr. Sudhir Kumar, Patna, Dr. Manish Kumar Singh, Bhagalpur, Dr. Pranshu Kumar, Gaya, Dr. A.K. Das, Muzaffarpur, Dr. Mahavir Thakur, Sitamarhi. The zonal members for this academic years are Dr. Vikas Singh, Patna, Dr. S.C. Jha, Darbhanga, Dr. R.R. Verma, Gaya, Dr. Chandan Kumar Singh, Purnia, and Dr. Vinay Dandania, Ranchi. The next point is venue for the next conference.
Just prepare a paper with all the members' telephone number, his address, and point of communication.
Yes, sir.
That is one. Second is email address, yes. And second is, because we are going to, as you are just declaring, we are going to have conference next in the Jamshedpur. So if house permit me, I can have a joint secretary or associate, any associate from Jamshedpur itself. So for smooth working.
Yes, sir. Yes. By protocol, it is needed, sir. President place or chairman place, joint secretary is there.
ठीक है सर, ठीक है,
इसको इंक्लूड कर लेते हैं।
तो हम लोग एक जो है हमारे कंस्ट्रक्शन में जो जॉइंट सेक्रेटरी हैं, तो हम लोग इनको जो है हेडक्वार्टर है नीरज कुमार है, एक राजीव झा के उनके कर देते हैं, राजीव झा को हम ले लेंगे।
ठीक सर, ठीक है,
देख लिया, क्योंकि दो आप ही बनाए हैं, दो एक चेयरमैन प्लेस आप उस समय मेंशन नहीं करें, कॉन्स्टिट्यूशन तो वही हाँ तो हो गया, कर लिया
ठीक है। नहीं, अगर राजीव पे मान सर से बात करके सर है यहाँ, दो के जगह पर 3 ज्वाइंट सेक्रेटरी करते तो
पिछले साल थे, कोई इशू नहीं,
तब ठीक है,
कोई इशू
तब
ले लेंगे,
तब ठीक है, तब ठीक, उसको खराब नहीं लगना चाहिए, नहीं ठीक है तब।
Venue for the next conference already announced by Dr. Umesh Khan sir. Any other matter with permission of chair? जी सर।
There is a central CCDSI WhatsApp group. We also want a separate group of Bihar Jharkhand. But we are not connected in that. Okay, there is a
अभी बिहार झारखंड का ग्रुप सर बहुत एक्टिव नहीं है, क्योंकि नेशनल टीम में ही हम लोग ये करते हैं, लेकिन ठीक है सर, क्लोज ग्रुप एक होना चाहिए डे टू डे अफेयर्स के लिए। सर ठीक है, आपका पॉइंट सर वेल टेकन। एनी अदर सजेशन और गाइडेंस फ्रॉम द गार्जियंस प्रेजेंट हियर?
Hey, we are doing very good here. I think you want to take this thing. Construction का ना तो इस कर गए उसको आपको एडमिट कर दीजिए कि वन फ्रॉम
वो कर लेंगे उसमें पास कर हाँ हो गया
आप प्रेसिडेंट बोलते हैं ना
चेयरमैन उसको लेना बाद में चेन्नई में लोगों ने कहा कि प्रेसिडेंट एक ही रहना चाहिए और बाकी स्टेट में सेंट्रल चेयरमैन चेन्नई में इसको ये किया
तो हम लोग ठीक ही जा रहे हैं
Okay, thank you, sir. The next agenda is address by Chairman-elect, Dr. Umesh Khan, sir.
Thank you, Dr. Sumit.
सर अभी एजीएम में 2 मिनट का एड्रेस करा देते हैं फिर वहां पे तो होगा.
Thank you, Dr. Sumit. On behalf of CCDSI, Bihar and Jharkhand, I thanks all the seniors, especially Dr. A.N. Rai sir, Dr. Thakur sir, Dr. Kamlesh Tiwari sir, Dr. Khetan sir, and all the seniors and junior colleagues for having faith on me. And I assure that I will try to keep it as high as I can. At the same time, I like to thank Dr. Rai sir for giving all the direction and support for making this association or conference successful. Other all seniors, Dr. Thakur sir, Dr. Kamlesh Tiwari sir, Dr. Khetan sir, Dr. Lal sir, every seniors have contributed large in making this conference success with the help of team of Dr. P.K. Singh and his whole team, Dr. Sumit, Dr. every colleague of his or him. So I thanks everybody and I welcome. Thanks all the seniors and colleagues for arranging very good conference today, and I think it will end tomorrow itself. Thanks.
Thank you, sir. The last agenda is vote of thanks. Respected members of the society, Gurus, Professor Dr. B.V. Thakur sir, Professor Dr. Rai sir, Professor Dr. Kamlesh Tiwari sir, Professor Dr. Lal sir, and all the seniors and colleagues. I am delighted that I am getting the 3rd year as a secretary of the state chapter, and really I serve the society by my heart. I thank all of you present here in AGM for guiding us. You are the strength, and your participation and enthusiasm is the guiding force for us. I thank you, all of you, Chairman sir, Chairman-elect sir, and all the dignitaries present in the AGM. Thank you, sir. Thanks again.
Hello. So once again, thank you so much to each one of you. And now we are all set for the very, very grand inauguration ceremony of our 7th annual conference of Clinical Cardio and Diabetic Society of India, Ccdsicon, Bihar and Jharkhand 2023. And without any further ado, without any further delay, I would now like to call upon stage our esteemed dignitaries, without whose uninstinted support it would have become extremely difficult and extremely cumbersome for each one of us to carry on with this program. So I would now like to call upon stage Dr. B.P. Thakur sir, who is the honorable chief guest of this wonderful conference. A very, very warm and a hearty welcome to you, sir, on behalf of our entire board of CCDSI. We're extremely honored and privileged to have you over here, sir. आपने अपना अत्यंत ही मूल्यवान व कीमती समय हमारे सम्मेलन के लिए निकाला, हम सभी लोगों के लिए निकाला। ये वाकई में बहुत ज्यादा मायने रखता है हम सभी लोगों के लिए। इसी के साथ अब मैं हम सभी के बीच, हम सभी के समक्ष हमारे विशिष्ट अतिथि के स्वरूप में डॉक्टर एस.के. लाल सर को आमंत्रित करना चाहूंगी मंच पे। डॉक्टर एस.के. लाल सर, उनके स्वागत व अभिनंदन में एक बार शानदार तालियां। आप सभी देख पा रहे हैं हमारे माननीय मुख्य अतिथि के स्वरूप में डॉक्टर बी ठाकुर मंच पर पधार चुके हैं। एक बार शानदार तालियां आनी चाहिए उनके स्वागत व अभिनंदन में। हमारे विशिष्ट अतिथि के स्वरूप में डॉक्टर एस.के. लाल सर से मैं अनुरोध करूंगी कि वो कृपया करके मंच पे आए। इसी के साथ साथ अब मैं अनुरोध करूंगी डॉक्टर कमलेश तिवारी सर, जो कि हमारे अत्यंत ही विशिष्ट अतिथि हैं और आज के इस आयोजन पे हमारे बीच उपस्थित हैं। मैं उनसे अत्यंत ही विनम्रता पूर्वक अनुरोध करूंगी कि वो कृपया करके मंच पे आए और हमारे टीम मेंबर से रिक्वेस्ट है कि पुष्प गुच्छ के साथ सभी गणमान्य अतिथिगणों का स्वागत व अभिनंदन मंच पे किया जाए। डॉक्टर कमलेश तिवारी जी भी अब मंच की शोभा बढ़ाने, गरिमा बढ़ाने मंच पे पधार चुके हैं। एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। I would now like to call upon stage Dr. A.N. Rai sir, the founder president of CCDSI. I will request him as well to join all the other dignitaries on the dais. Dr. A.N. Rai sir, the honorable founder president of CCDSI. I would also like to request Dr. P.K. Singh sir, the chairman of CCDSI, Bihar and Jharkhand. Dr. P.K. Singh sir, the honorable chairman of CCDSI. I would also like to call upon stage Dr. Umesh Khan sir, the honorable chairman elect CCDSI, Bihar and Jharkhand. Let's have a huge round of applause for all these really amazing and inspirational personalities. और अब मैं मंच पे आमंत्रित करना चाहूंगी श्री मृत्युंजय कुमार सिंह सर, सेक्रेटरी CCDSI। डॉक्टर मृत्युंजय कुमार सिंह सर, जो कि हमारे CCDSI के सेक्रेटरी हैं, माननीय सेक्रेटरी, मैं उन्हें भी मंच पे आमंत्रित करना चाहूंगी। एक बार शानदार तालियों के साथ चलिए आइए उनका अभिनंदन व स्वागत करते हैं। और also like to call upon stage Dr. Vinay Kumar sir, the chairman of reception committee. I request him as well to join all the other dignitaries on the stage. Dr. Vinay Kumar sir. I would also like to call upon stage Dr. Ajit Kumar Sinha sir, the chairman of scientific committee of CCDSI. Ajit Kumar Sinha sir would also request you to join us for the inauguration ceremony. I would also like to call upon stage Dr. Abhishek Kumar sir, the secretary of CCDSI Bihar and Jharkhand. Dr. Abhishek sir, I would very humbly request you to kindly come upon the dais. And last but definitely not the least, I would like to call upon stage Dr. Sumit Kumar Verma sir, the organizing secretary of Ccdsicon, Bihar and Jharkhand 2023. Let's have a huge round of applause for him. एक बार थोड़ी शानदार तालियां आनी चाहिए मंच की शोभा और गरिमा बढ़ाने के लिए। अब हम सभी के बीच, हम सभी के समक्ष पधार रहे हैं डॉक्टर सुमित कुमार वर्मा सर, जो कि हमारे ऑनरेबल ऑर्गेनाइजिंग सेक्रेटरी हैं CCDSicon के। आप सभी गणमान्य अतिथिगणों से यह अनुरोध है कि आप लोग कृपया करके मंच पे आसीन हो जाएं, विराजमान हो जाएं। और हमारे टीम मेंबर से रिक्वेस्ट है कि सभी गणमान्य अतिथिगणों का स्वागत वो पुष्प गुच्छ के साथ संपन्न करें। एक बार शानदार तालियां आनी चाहिए। और तालियां बहुत ही फीकी आ रही हैं, थोड़ी शानदार तालियां, ऊर्जावान तालियां आएंगी तो बहुत ही अच्छा लगेगा। और इसी के साथ अब मैं आगे बढ़ना चाहूंगी And in order to deliver the welcome address, I would now like to call upon the dais, our Honorable Chairman of the Reception Committee, Dr. Binay Kumar sir, who is already present with us. I will request him to kindly address all the really wonderful and honorable delegates present on this very wonderful occasion. A very, very warm welcome to you, sir.
Respected distinguished guests, delegates, colleagues, friends, ladies and gentlemen. I, as a member of reception committee, chairman of the reception committee of CCDSI conference, and chairman of Begusarai API, feel pleasure and pride to welcome you in Begusarai, which is industrial capital of Bihar, having many big industries like IOC, HFC, Super Thermal Power Station, Sudha Dairy, and so many small industries. Apart from these, Simariya Ghat, Jaimangala Devi Temple, Kabar Jheel, Nolakha Temple are places where you may visit and will feel peace and harmony. This vibrant place have given multiple great persons in various spheres of human activities like politics, literature, poetry, philosophy, etc. In recent past, national poet Sri Ramdhari Singh Dinkar, national historian Sri Ramcharan Sharma, grown from this vibrant land. I have really great pleasure and have to say that so many legend physicians have come. Sir, you all are the legend of medical world, and let your light be shine before us so that we may see your good and great work. Ladies and gentlemen, I repeat a sentence of Francis Bacon that reading make a full man and conference make a ready man. I believe that each one will be able to return home from this conference richer in knowledge and will feel happier after interaction with the fellow delegates and speakers from different parts of the country. But ladies and gentlemen, we are aware of some shortcomings and feel shaky in admitting without hesitation that we have fallen in some ways. We have tried to do our best to provide you best facilities, but probably not up to your expectation, as I feel. We hope you will bear with our faults and will help us to make the conference as a great success. At last, I welcome you all again. Let us make this conference memorable. Jai Hind and regards to all.
Thank you so much, sir. And I request each one of you to kindly put your hands together for sir as he expresses his thoughts and views and experiences with all of us in a very remarkable manner. So without any further ado, I would now like to move ahead. बिना किसी विलंब के हम मैं आगे बढ़ना चाहूंगी और हम सभी जानते हैं कि हमारे भारत देश में ये स्वर्णिम और बहुत ही प्राचीन परंपरा रही। किसी भी शुभ कार्य की शुरुआत दीप प्रज्वलन की अत्यंत ही मांगलिक व शुभ विधि के साथ ही होनी चाहिए और आज भी हम लोग यही करने वाले हैं। दीप को बहुत ही सुंदर तरीके से, अनुपम तरीके से यहाँ सजाया गया है। तो आप सभी गणमान्य अतिथिगणों से ये अनुरोध है कि आप लोग कृपया करके अपने कर कमलों द्वारा दीप प्रज्वलन की विधि को यहाँ संपन्न करें। एक बार थोड़ी शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। आप देख पा रहे हैं हमारा ये 7th एनुअल कॉन्फ्रेंस ऑफ क्लिनिकल कार्डियो एंड डायबिटिक सोसाइटी ऑफ इंडिया बिहार एंड झारखंड 2023। अब इसका शुभारंभ दीप प्रज्वलन की विधि के साथ विधिवत तरीके से, अत्यंत ही मांगलिक तरीके से हम सभी के बीच हो रहा है। थोड़ी तालियां आएंगे आप सभी लोगों की तो और भी ज्यादा अच्छा लगेगा। आपकी तालियां हमारे लिए ऊर्जा का, मनोबल का सबसे बड़ा स्रोत है, तो अपनी तालियों में कंजूसी ना करें, बिना किसी संकोच के तालियां बजाएं। और आप सभी देख पा रहे हैं दीप प्रज्वलन की विधि यहाँ संपन्न हो रही है। सभी नकारात्मक ऊर्जाएं नष्ट हो रही हैं और पूरे वातावरण में सिर्फ और सिर्फ सकारात्मकता और सकारात्मक ऊर्जाएं ही अब विद्यमान है। मेंबर से रिक्वेस्ट है कि आप प्लीज लैम्प को स्टेज के नीचे प्लेस कर दें। एक बार शानदार तालियां आनी चाहिए। लेट्स हैव अ ह्यूज राउंड ऑफ अप्लॉज for all the esteemed and honorable dignitaries for doing the honors, for performing the lamp lighting session over here. And since the lamp lighting ceremony has been successfully performed, I would now like to proceed further, and I would now like to invite our Honorable Secretary of CCDSI, Bihar and Jharkhand, to kindly deliver a report, Secretary report. And in order to do this, I would now like to call upon Dr. Abhishek Kumar, sir. Once again, a very, very warm welcome to you, sir.
Thank you, Muktaji. Respected Chief Guest, Professor Dr. B.B. Thakur, sir. Guest of honor, Dr. Kamlesh Tiwari, sir. Guest of honor, Dr. Lal, sir. Founder President, Professor Dr. A.N. Rai, sir. Chairman, State Chapter, Dr. P.K. Singh, sir. Chairman-elect, Dr. Umesh Khan, sir. Scientific Chairman, Dr. Ajit Sinha, sir. Reception Committee Head, Dr. Binay Kumar, sir. Secretary General, Dr. Mrityunjay, and the Organizing Secretary, Dr. Sumit Kumar Verma, dignitaries of the dais, and all the members of the society. I am privileged to present the Secretary's report of CCDSI Bihar and Jharkhand chapter for this session 2022-23. We took over the office of CCDSI Bihar and Jharkhand chapter for this academic year 22-23 from the first week of April 2022. Our aim was to do regular academic activities, increase members, promote digital record keeping, and to make the activities of society more accessible to the masses. The important works we completed in our tenure under the leadership of State Chairman Dr. P.K. Singh Sir. We conducted regular CMEs both in the physical and online mode at various places across the state, covering various topics of cardiology, diabetology, nephrology, neurology, rheumatology, lipid disorders, and the infectious diseases. Also, we try to involve postgraduate students and general practitioners in our CMEs. I am happy to announce that over the year, the students of PMCH Patna, NMCH, AIMS Patna, Jawaharlal Nehru Medical College Bhagalpur, and Anugrah Narayan Memorial Medical College Gaya did significant participation in our academic and social activities. In this conference also, we are having a postgraduate session, which is scheduled tomorrow, and it is happening first time in the history of state chapter of CCDCI. In our peripheral outreach plan, we conducted a CME and membership drive on 26th of June 2022 in West Champaran district in association with district branch of IMA, which was very successful. I am thankful to the senior physician Dr. K.S. Jha sir for all the support. Our midterm falls in the month of September, October, and that coincides with our national conference. Thus, midterm conference at larger level is not feasible. However, this time we did a CME on lifestyle modifications on 11th of September 2022 in Patna in association with Patliputra National Kidney Foundation. The CME was a huge success in which the audience were diabetologist, cardiologist, nephrologist, urologist, surgeons, gynecologist, pediatrician, community medicine expert, dietitian, OT technician, dialysis technician, various press reporters, and common people from various aspects of the life. So I think it served the target audience of CCDSI as visioned by our founder president, Dr. Professor N. Rai sir. I am thankful to Dr. Gururaj B. Sattur who traveled from Hubli, Karnataka to grace us on that occasion and deliver the talk. I am also thankful to Dr. Professor Hemant Kumar sir, the president of Patliputra National Kidney Foundation, for associating with us and supporting us. We observed World Heart Day, World Diabetes Day, World Kidney Day, in which the free health camps and the disease awareness drive was done at various places of Bihar and Jharkhand under the banner of CCDSI. I am thankful to all district branches for their marvelous contributions. Our proud members of the state, along with the national team, met Honorable Governor of Sikkim, Sri Ganga Prasad Ji, in July 2022, and Honorable President of India, Srimati Draupadi Murmu, in November 2022. And this is also a big achievement in the banner of state chapter of CCDSI. In membership drive, we made more than 20 members in this academic years in various districts. And today I am happy to announce the formation of 3 new city branches, we call it district branches, at Begusarai, Jamshedpur, and Ranchi. I congratulate the members of the district for the same. And finally, we are conducting our annual conference under the able guidance of our chairman and organizing chairman, Dr. P.K. Singh sir, which is going on now. However, we lagged in few things like frequent physical meeting in outskirts of the state and more involvement of general practitioner. Also, at research level, we are lagging. We hope to cover these in coming days. Thank you. Thanks a lot.
Thank you so much, sir. And I would now like to call upon Dr. P.K. Singh, sir, who is the Honorable President and Organizing Chairman of Ccdsicon, Bihar and Jharkhand 2023. Now he's going to address all of you. So let us all welcome him with a huge round of applause.
इस महत्वपूर्ण संध्या में हम अपने चीफ गेस्ट डॉक्टर बीबी ठाकुर सर, गेस्ट ऑफ ऑनर डॉक्टर एस.के. लाल, डॉक्टर कमलेश तिवारी, फाउंडर प्रेसिडेंट डॉक्टर एन राय, इनकम्बेंट चेयरमैन डॉक्टर उमेश खान, चेयरमैन साइंटिफिक कमेटी डॉक्टर अजीत कुमार सिन्हा, नेशनल सेक्रेटरी डॉक्टर मृत्युंजय कुमार, चेयरमैन रिसेप्शन कमेटी विनय जी, ऑर्गेनाइजिंग सेक्रेटरी सुमित कुमार वर्मा और अपने बहुत ही एनर्जेटिक सेक्रेटरी स्टेट, सबों के बहुत शुक्रगुजार हैं। आप लोगों ने फील किया होगा कि CCDSI, जैसा मैंने फील किया है, CCDSI एक ऐसा ऑर्गेनाइजेशन है जिसमें आप एक परिवार की तरह की फीलिंग प्राप्त कर सकते हैं। कहीं भी जब भी हम लोग साथ गए हैं किसी भी कॉन्फ्रेंस में, लगता है कि परिवार के एक सदस्य एक दूसरे से मिल रहे हैं, फुल ऑफ एकेडमिक इन्वायरमेंट। हमारे स्टेट में एक से एक टैलेंट है, लोगों की प्रैक्टिस बहुत अच्छी है, क्लिनिकल एक्यूमेंट बहुत है, हम लोग खाली कमजोर हैं तो डाटा में, उसको रिकॉर्ड नहीं करते हैं। अभी बात चल रही थी जो डायबिटिक रेमिशन की, तो मैंने डॉक्टर इंद्रा सर से कहा मेरे पास 2 पेशेंट्स हैं। एक पेशेंट ऐसा था कि जिसको बहुत दिन तक 3-4 साल तक टेबलेट और बाद में इंसुलिन पर मैं रखता था, बाद में मेरे इलाज से बाहर हो गया और जब दोबारा आया कभी तो फिर जांच कराए, हम सोचे इसका डायबिटीज बहुत बढ़ा हुआ होगा, तो उसका बिल्कुल नॉर्मल था। मैंने इंक्वायर किया कि भाई आप कुछ दवा ले रहे हो, तो कोई दवा नहीं ले रहे हैं। और उसके बाद से जब भी आता है तो हम जांच कराते हैं और उसका डायबिटीज नहीं निकलता है, और वो कहता है सर क्यों बार बार आप जांच कराते हैं। मेरे पास उसका पूरा डिटेल्स नहीं है। हमने इंक्वायर किया कि आपको उसमें कैसे हुआ था, कोई स्ट्रेस हुआ था, कुछ हुआ था, लेकिन उसने ऐसा कुछ नहीं बताया। ऐसा ऐसा केस रहता है। और एक दूसरा भी है जिसका कि डायबिटीज की ओरल हाइपोग्लाइसेमिक चलता था और वो अभी कोई दवा नहीं ले रहा है, फिर भी उसका डायबिटीज कंट्रोल्ड है। तो केसेस बहुत हैं। हम आप लोगों से गुजारिश करेंगे, जैसा कि हम भी नहीं करते हैं, हमको भी करना चाहिए, सबों को करना चाहिए। जो भी केसेस है उसका डाटा, उसका जो भी हिस्ट्री, इस सब को रख करके और इस तरह के कॉन्फ्रेंस में एक दूसरे से शेयर करें, और उससे हमारा एसोसिएशन ज्यादा रिच और वाइब्रेंट होगा। चाहे वो एपीआई हो, चाहे सीसीडीएसआई हो, सबों का एम एक है कि हम लोग एकेडमिक इन्वायरमेंट बनावें, ज्यादा पब्लिकेशन हो, ज्यादा एक दूसरे से आदान प्रदान हो, और नेट रिजल्ट जो आम लोग हैं उनको इसका लाभ मिले। एक आदमी ने अगर कोई चीज देखी और कुछ अच्छा चीज फील किया और उसके दिमाग में कोई ब्राइट आइडिया आया तो उसको शेयर करने से ही वो जनहित में जाएगा। तो ये सारी बातें हैं। हम लोगों को मेंबरशिप बढ़ाना है। अभी बेगूसराय में तो 10 मेंबर का नाम चला गया है और एसोसिएट मेंबर भी अच्छी संख्या में यहाँ होंगे, ऐसा हमको इंफॉर्मेशन दिया गया है। बेगूसराय इज इन इट्स नेचुरल रिदम। कहीं नहीं लग रहा हो कि कोई स्ट्रेस है, सब आदमी नॉर्मल रिदम में आए, डेलिब्रेशन सुने और उसका लाभ उठाए, और अभी भी बैठ करके इसमें माहौल को बिल्कुल खुशनुमा बनाए हुए हैं, बिल्कुल शांति है। ये बेगूसराय की विशेषता है। जब भी कोई जरूरत पड़े, कोई दुर्घटना हो जाए, तो जिले के सरकारी डॉक्टर या प्राइवेट डॉक्टर सब के सब वहां उस जगह जमा हो जाएंगे, और कोई भी तरह की कोई समस्या होती है तो ऐसा लगता है कि सब एक दूसरे से वेल कनेक्टेड हैं। तो बेगूसराय ब्रांच अब बनने जा रहा है, और बेगूसराय ब्रांच की हैसियत स्टेट में और नेशनल लेवल पर भी बढ़े, ऐसा हम लोगों को सोचना चाहिए। और इसमें हम लोगों को हमारे जो सीनियर्स हैं उसका उन लोगों का योगदान और दिशा निर्देश मिलते रहेगा, ऐसा मुझे पूर्ण विश्वास है। और ज्यादा समय क्या कहें, जो भी है, जो भी संभव हो, हम लोगों को साथ मिलकर के इस तरह का बनाना है कि सीसीडीएसआई या एपीआई जो भी एसोसिएशन हैं वो बिल्कुल वाइब्रेंट रहें और जिले में उस तरह का माहौल हो। धन्यवाद।
Thank you so much, sir. And I will request each one of you to kindly put your hands together for sir. एक बार शानदार तालियां आनी चाहिए सर के सम्मान में आप सभी लोगों की ओर से। और इसी के साथ अब मैं पुनः अविलंब आप सभी के समक्ष अनुरोध करना चाहूंगी हमारे माननीय सेक्रेटरी सीसीडीएसआई डॉक्टर अभिषेक कुमार सर को, ताकि वो चेंज ऑफ गार्ड इस प्रोसेस को टेक ओवर कर सके। थैंक यू सो मच।
Thank you. Now it is time to change of guard, and the current chairman, Dr. P.K. Singh sir, will provide medallion to incoming chairman of the state chapter, Dr. Umesh Khan sir. Please, आगे सर आ जाइए. ये सिंप्रदान टाइप का प्रोसेस होता है, काफी इम्पोर्टेंट. Thank you, sir. Now I request the chairman of the state chapter, Dr. Umesh Khan sir, for his address.
Respected Chief Guest, Dr. B.B. Thakur, Guest of Honor, Dr. S.K. Lal, and Dr. Kamlesh Tiwari, Chairman, immediate past Chairman, Dr. P.K. Singh, his whole group, Dr. Vinay Kumar, Chairman, Reception Committee, Dr. K.K. Lohani, my best friend, Dr. Khetan sir, Dr. Arya, Dr. Singhal, all other dignitaries and officials from different pharma company, friends from different media, and at last Dr. R.K. Jha is not there, but Dr. R.K. Jha, who has given all support to organizing this committee, is one of the best hall of Baroni. Dear sir, I feel honored to be here as a president of our August Association CCDSI. At the outset, I would like to thank all my seniors, fellow colleagues of CCDSI for giving me this opportunity and your faith on me. I assure you that all efforts will be done in taking CCDSI activity to higher height with support of all your seniors, colleagues, and even all our doctors' friends from this Begusarai. I have worked in IMA as a president for 5 years in Jamshedpur. And I like to tell you that our association may be API, I'm a president of API also. So maybe API or CCDSI, we are taking care of our education, but we should take care of, nowadays it has come that we should take care of our personal problem. If any of our colleagues get any type of physical or mental problem, we should be together and help by whole Bihar or Jharkhand area, and not only Bihar or Jharkhand, whole India, as we have seen in Rajasthan. If the doctors would have not been combined, had this effort, then this bill would have ended the private practitioners. So this is the high time that we becomes one and one. Thank you.
Thank you so much, sir. And I would now like to call upon our Honorable Founder President of CCDSI, Professor Dr. Ian Rai, sir. I request him to kindly address all the delegates and all the people present on this wonderful and special occasion.
Our chief guest of today, Dr. B.V. Thakur, guest of honor, Dr. B. Lal and Dr. Kamlesh Tiwari. Now, newly installed President Dr. Umesh Khan, immediate past Chairman, newly installed Chairman Dr. Umesh Khan, immediate past Chairman Dr. P.K. Sinha, Dr. Mrityunjay Kumar, National Secretary, Dr. Abhishek, Secretary of the State Chapter, and Dr. Binay Kumar, Chairman Reception Committee, and Dr. Sumit Kumar, Organizing Secretary. I think we must give great credit to the organizing committee of this Begusara conference for arranging such a nice conference, and give a big hand in form of hospitality as well as scientific program. I think the selection of a scientific program was so good. You see what happened in most of the conference we go where we get talks is always high-fi, but here the talks were mostly clinical, and which is applicable to we clinicians here in Bihar. Now, my message to all of you is the same, which we, the member of the national team, core team, met our Honorable President, Srimati Draupadi Murmu, in October, and on behalf of CCDS, I was asked to give the message, and this message, I am just going to read what I gave to her. The mankind is under unprecedented attack by the non-communicable diseases which are related to lifestyle. These diseases includes obesity, diabetes mellitus, hypertension, and heart disease. As per a WHO prediction, by 2030, these diseases are going to affect more than 2/3 of the Indian population. This can be prevented by mass awareness of the important and telling the importance of lifestyle modification by controlling diet and weight, regular exercise, minimum half an hour for 5 days a week, stopping smoking, controlling hypertension, diabetes, blood and blood cholesterol. Cardiodiabetic Society of India has taken responsibility for mass awareness of importance of lifestyle modification by arranging regular screening of camps for diabetes, hypertension, and heart diseases in rural areas, and updating our doctors by having regular CME and annual conferences. Till now, I think I would like to achievement in the last span of 6 years, what we have achieved. In the last span of 6 years, we have got our national headquarters built at Gaya. This is with the support of all of you, we are having a headquarter building at Gaya. Second thing, we have got now 9 state chapters and 2 are in pipeline. The 9 state chapters are this Bihar and Jharkhand, we all know. Then it was Chennai, then Odisha, Gujarat, West Bengal, UP, Haryana, Rajasthan, already there. And 2 are in pipeline, that is Maharashtra and Karnataka. So in such a short span, with the support of all of you, we are going to have this organization, one of the leading organization covering all the important diseases, that is hypertension, diabetes, cardiac disease, and other metabolic diseases, kidney disease and other metabolic diseases. Thank you very much.
Thank you so much, sir. It was an absolute pleasure for all of us to hear you share your opinions and thoughts. And I would now like to call upon, before all of you, our guest of honor, Dr. Kamalesh Tiwari, sir. I request him to kindly share his thoughts, views, and experiences with all of us on this very, very special occasion. And ladies and gentlemen, could you please put your hands together in order to welcome sir?
Incoming Chairman, Dr. Khan, outgoing Chairman, Dr. P.K. Singh, and members of organizing team of Begusarai, my senior, Professor Thakur, and Dr. Lal, and Dr. A.N. Rai, who is also founder president of this association, dignitaries on the dais, my friends, my colleagues, ladies and gentlemen. First of all, I would like to congratulate the team Begusarai for organizing such a nice conference of CCDSI in Begusarai. And I must congratulate Dr. Rao also that this organization is doing very well nationwide. It is good. We should feel proud that the organization started from Bihar and it is doing in the whole nation. That is a matter of pride for all of us. Second, this conference is nicely arranged. I appreciate Dr. P.K. Singh for choosing nice scientific taste and nice hospitality to the members. I will wish a very successful CCDSI at Begusarai. Thank you very much.
Thank you so much, sir, for sharing your thoughts and views with all of us in such a wonderful manner. And now we are all set to head towards one of the most awaited moments of this very special evening. And yes, ladies and gentlemen, I'm talking about the felicitation ceremony, which is now going to take place. And therefore, I will request our honorable chief guest, Dr. B.B. Thakur, sir. I will request our honorable chief guest, B.B. Thakur, sir, to kindly extend this very beautiful, this very, very important, and this very significant.
Friends, actually, I feel honored. I feel humbled to felicitate one of the mentors, one of my mentors. If he would not have been there, if his friends and colleagues would not have been there, then possibly I would not have been on this chair. So I feel proud, privileged, and honored to felicitate Dr. S.K. Lal, who is like my guardian.
और आप सभी देख पा रहे हैं हमारे आज के इस आयोजन के माननीय मुख्य अतिथि श्री बीबी ठाकुर जी हमारे अत्यंत ही विशिष्ट अतिथि के स्वरूप में उपस्थित डॉक्टर एस.के. लाल सर को सम्मानित कर रहे हैं कर कमलों द्वारा और ये लाइफ टाइम अचीवमेंट अवार्ड ये ऑनर उन्हें दिया जा रहा है हमारे माननीय मुख्य अतिथि के कर कमलों द्वारा श्री बीबी ठाकुर जी के हाथों से ये अवार्ड उन्हें मिल रहा है एक बार शानदार तालियां आनी चाहिए सभी लोगों के लिए It's a very precious moment. It's a very beautiful moment for each one of us. Yes, sir. And what a really delightful moment it is for our entire.
For your kind information, only few weeks ago, me and Dr. Kamlesh Tiwari had come to this place to felicitate Dr. Lal on behalf of Central API.
And I would now request the founder president of CCDSI, Dr. A.N. Rai sir, to kindly honor our honorable chief guest for this occasion, B.B. Thakur sir. एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से डॉक्टर B.B. Thakur sir. जो कि हमारे माननीय मुख्य अतिथि हैं, उन्हें सम्मानित किया जा रहा है। और अब एएन राय सर से मैं पुनः अनुरोध करूंगी कि वह हमारे बीच उपस्थित कमलेश राय सर, कमलेश तिवारी जी को सम्मानित करें, जो कि हमारे विशिष्ट अतिथि हैं। एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। और अब मैं हमारे CCDSICon के प्रेसिडेंट और ऑर्गेनाइजिंग चेयरमैन PK सिंह सर से अनुरोध करूंगी कि वो हमारे CCDSI के फाउंडर प्रेसिडेंट प्रोफेसर डॉक्टर AN राय सर को सम्मानित करें अपने कर कमलों द्वारा। शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। थोड़ी शानदार कमाल की तालियां लोगों की ओर से। And I would now request the organizing secretary, Dr. Sumit Kumar Verma, sir, to kindly honor our honorable chairman of the reception committee, Dr. Binay Kumar, sir. एक बार शानदार तालियां आनी चाहिए। और अपना मैं डॉक्टर सुमित कुमार वर्मा जी से यह अनुरोध करूंगी कि वो हमारे प्रेजेंट चेयरमैन CCDSICon डॉक्टर उमेश खान जी को सम्मानित करें अपने कर कमलों द्वारा। एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। और अब मैं सुमित सर से ये रिक्वेस्ट करूंगी कि वो हमारे बीच उपस्थित डॉक्टर अजीत कुमार सिन्हा सर को सम्मानित करें। और अब मैं अनुरोध करूंगी सुमित सर हमारे बीच उपस्थित डॉक्टर मृत्युंजय सर को सम्मानित करें अपने कर कमलों द्वारा। एक बार थोड़ी शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। And once again, I would request Sumit Kumar Verma sir to kindly honor the Secretary of CCDSI Bihar and Jharkhand, Dr. Abhishek Kumar sir. And what a beautiful moment for each one of us. And last but definitely not the least, I will request our Honorable Founder President of CCDSI, Professor Dr. Ian Rai sir, to kindly honor our Honorable Organizing Secretary, Dr. Sumit Kumar Verma sir. Let's have a huge round of applause for Sumit sir and for his untiring efforts, for his commendable efforts, for his relentless efforts that he has put into in August to organize this event in such a wonderful and meticulous manner.
In continuation with the felicitation ceremony, a tradition was started during the last session by then chairman of the state chapter, Dr. KK Lohani sir, that we are giving 4 best awards in 4 categories to various districts of the state chapter. and that is called the Chairman's Appreciation Award. So I would like to call upon the names, and the members will come to the dais and receive the Chairman Appreciation Award for year 22-23 by outgoing Chairman Dr. P.K. Singh sir and current Chairman Dr. Umesh Khan sir combinedly. The best district branch goes to Gaya. I request Dr. R.R. Verma sir to please receive the Chairman's Appreciation Award for best district. The district has contributed continuously in the academic and the social platform of CCDSI state chapter. The best district chairman award goes to Chairman of Bhagalpur district, Dr. Abhilesh Kumar. From Bhagalpur, no one is here, I think. So, may I request Mrityunjay sir, आप ही रिसीव कर लीजिए. Actually, most of the members of Bhagalpur are attending the API meeting today, and IMA meeting is also going there. The best secretary, district secretary, goes to Secretary of Patna district, Dr. J.K. Dinkar. And Dinkar has got baby girl yesterday, so he is not here, but he is attending this ceremony on the YouTube. I request Dr. Sudhir Kumar sir from IGMS to receive this award on behalf of Dr. J.K. Dinkar. The fourth one is most committed member of state chapter for year 2022-23, and that award goes to Dr. Gagan Gunjan from Ranchi. Gagan is already here. Please come and receive the award. Dr. Gagan is active in so many platforms, and for CCDSI, he has become super active in last session. I congratulate all the award winners for this session. Thank you. Mukta.
Thank you so much, Abhishek sir. And let's have a huge round of applause for Abhishek sir as well. एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से. और इसी के साथ अब मैं आगे बढ़ना चाहूंगी और हमारे बीच जैसा कि आप सभी देख पा रहे हैं अत्यंत ही विशिष्ट अतिथि के स्वरूप में उपस्थित हैं डॉक्टर एसके लाल सर. और अब मैं उनसे अनुरोध करूंगी कि वो अपने विचारों को, अपने अनुभवों को हम सभी के समक्ष रखें, हम सभी के समक्ष व्यक्त करें, प्रकट करें. एक बार शानदार तालियों से चलिए आइए उनका स्वागत व अभिनंदन करते हैं आज के इस अत्यंत ही शानदार मंच पे. बहुत बहुत स्वागत है सर आपका.
Chairman Dr. Khan, immediate past chairman Dr. P.K. Singh, chief guest Dr. B.G. Thakur, Founder, President, Dr. N. Roy, Dr. Kamalesh Tiwari, Dr. Ajit Kumar, Dr. Sumit Kumar Verma, other dignitaries on the dais. First of all, I express my thanks whenever I have been honored at this August gathering. Ladies and gentlemen, this is a proud moment for people of Begusara, particularly doctor community. Such an August conference of clinical cardio diabetic society in Bihar and Jharkhand. Deeply honored not only doctor community, but as a senior citizen of Begusara, I extend my heartiest welcome and thanks for hosting this conference on the soil of Begusara. Ladies and gentlemen, this important segment of the clinical medicine, the society has taken upon the task of serving the community as well as the health services in befitting manners. We know that army of doctors is being produced, and in future, when each district is going to have medical college, you can imagine when there is a dearth of qualified teachers and lack of proper equipment, there is fear that under graduates and postgraduates may be substandard by such institutions. And this society can serve better in propagating the modern medicine in befitting manners. So there is necessity of such an organization. There is talk of India being made Vishwa Guru. Ladies and gentlemen, this appears very, very big thing, but as a doctor of this age, who have seen ups and downs, this is not a big task. I have seen how medical science has developed in this country. There was practically very, very little. We were lagging far behind the developed nations. But today we feel proud that medical science in our country has developed to such a level that we can say that this is almost at par with the developed nations. And when we say that we are going to be Vishwa Guru, not in the realm of philosophy, but in other fields of human activities, of which medicine also is an important part. So ladies and gentlemen, don't think the task is too big. We can do it. We can become Vishwaguru. We have seen our talents. Who could imagine some time back that our a man of Indian origin will occupy 10 Downing Street by becoming the Prime Minister of UK? This was unthinkable, unimaginable. But Indian talent has done it. Who could imagine an Indian origin person could occupy the seat of Vice President of United States? And in many countries, Indians have done well and are doing well. So don't think when our leaders say that we have the potentialities of becoming Vishwaguru, we can do it. I have mentioned this Vishwaguru in the sense that this society named in full as Clinical Cardio Diabetic Society of India, Bihar and Jharkhand have started very well. They are doing very well. They are serving this segment of cardiac and pulmonary, which forms an important part of internal medicine. And I'm sure that the devotion and enthusiasm of which they are doing, members are doing, they can achieve laurels, many laurels. So with these few words, I will conclude by saying that this society has great future. You can do miracles. And in the future, this society is going to be very big and will serve the society well. I wish the society a great success in the future. Thank you, ladies and gentlemen.
Hello. Thank you so much, sir. And let's have a huge round of applause for sir. In a very beautiful manner, he shared his thoughts and views with all of us. And we are once again extremely grateful to you, sir, for your very important and very inspiring presence over here. And now I would like to call upon the dais, our honorable chief guest for this occasion, Dr. B.P. Thakur, sir. I will request him to kindly share his views and opinions with all of us.
Om Shanti, friends. सबको मेरा नमस्कार. बड़ों को प्रणाम, छोटों को आशीष. I am conscious of the fact that the music has started. I am also conscious of the fact that many of you might be feeling hungry. And you will like that I should finish it quickly. And in that context, one dialogue of Sole, I remember. When Basanti said, मैं बोलती कहाँ हूं, तो मैं भी वैसा ही करूंगा जैसा बासंती ने किया था. So, Honorable Chairman of CCDSI, Dr. Umesh Khan, immediate past Chairman, Dr. P.K. Singh, my mentor, Dr. S.K. Lal, Dr. Kamlesh Tiwari, Dr. A.N. Rai, Dr. Binay, my student, Ajit Kumar Sinha, Dr. Abhishek, Sumit, and dynamic and gorgeous master of ceremony. I won't say Mrs. Ceremony. it's always master of ceremony. Then, dear delegates, without you, no conference is a success. Ladies and gentlemen, pharma friends, members of the press and media, I see so many friends in front of me. If I go on naming them, it will take a lot of hours. But I see my student, Dr. Khitan, Dr. Lohani, dynamic professor of IGIMS, Dr. Sudhir, Dr. S.C. Jha, and many more. So friends, I will tell you one story. When this organization was conceptualized, we were always talking, me and Dr. Rai. I was suggesting him, can I sit and talk? I was suggesting him that let us go for technology, because technology in diabetes and hypertension were coming very fast every day and night. But he told me that let us go for clinical cardiodiabetology. He emphasized on clinical. Unfortunately, before that, I got one news from USA, many of you might be knowing. There was a procession for funeral of clinical medicine. Actually, it was held in US. Clinical medicine's funeral was held. And during this pandemic, actually this clinical medicine was put on the backyard. And the time came when we started examining the patient through teleconsultation, and it has been now a recognized method of patient examination. But nothing can surpass, I tell you friends, a clinical medicine. What we were taught, believe me or not, I have been the professor and head of medicine for long 14 years. During those years, when it used to be reasonably tough, but I tell you honestly, I knew nothing except Hutchison. I'm honest. I read only Hutchison and nothing else. That was the time of clinical medicine. That was the time that you could diagnose the patient by just seeing, by just palpating his hands, by just looking into all the arteries, by just looking to the eyes, by just looking to his smile. And that was the time. But nowadays, we have just away from that clinical medicine. I was listening to Abhishek's talk, and I was actually delighted to see that he was emphasizing on clinical medicine. I put one question to you, sirs. How many of you are taking proper history, devoting proper time in taking the history only? One of the cardiac surgeon is sitting, yaar, suno, tere liye baat kar rahe hain. One of the cardiac surgeon is sitting beside me. I tell you, dear, if only history is taken properly, especially in angina, many more diagnoses can be made. And by not taking history properly, many people sustain myocardial infarction. At least I know of few. He goes to the doctor with some pain somewhere here and there. Goes to the doctor with a history of some burning sensation, some pain in the retroesternal region. the doctor doesn't give much attention. He does ECG, he takes a ECG, ECG is normal. Friends, the only method to diagnose angina is the history and history alone. All investigations would be normal. So that is the value of clinical medicine. Dr. Rai has very rightly pointed out about the non-communicable diseases. I will advise Dr. Rai, you see, we all are educated. We all know what have been taught here. Or we show that we know it. You are talking, I am moving in the stalls. There are 4 types of delegates. One is ordinary delegate who will sit in here. One is a stalwart delegate who will be in a stall. One is an extraordinary delegate who will come, get attend. I'm not talking of this meeting. In this meeting, the attendance was very good. So friends, what I wish to convey to you, that we must try to educate people more than doctors. Because if people are educated, if people know why they are falling ill, how many of you spend time with a diabetic patient knowing his family history, about his mama, about his mausa, about his mausi, about his uncle, about the uncle's son. Believe me, just day before yesterday, when I started looking to it, 10 people were diabetic in the family. So that is the message that I would like to give, that we must devote more time in public education rather than our education. That is very important. And I tell you, I have been doing it for the last 10 years unsuccessfully. I have a book known as जीवन शैली संबंधित बीमारियां निदान एवं बचाव. At least 10,000 books I have distributed, but of no utility. So that is what I mean to say. And then advice to Dr. Rai that like API, we should go for PG members also. Charge 50% of the membership fee, make them members, and then when they pass the MD or DNB, whatever it is, then you can make them full member. Some of our friends referred about Rajasthan. Actually, they have done commendable job. We have been watching their activities, and they have been doing commendable job, and they have succeeded it. So only designated hospitals and the government hospitals are under the banner of RTH. Do we have that strength in Bihar? My answer will be no. Another point that I will like to congratulate Dr. Rai, that in API we say Bihar, Jharkhand, Umesh. But he has translated it into action. And this organization is mainly Bihar and Jharkhand. So these are the few things that have come in my mind. So my take-home message to you is that for God's sake, spend some more time with your patients. As you are attending the clinical medicines department organization, so learn to spend some more time with your patients, and you will be doing immense service to your patients. With these few words, not like Basanti, I take leave of you, and I want to stand between you and your food. And I must thank Dr. P.K. Singh and Dr. A.N. Rai for having invited me to come to this place. I feel smaller in being chief guest in presence of my mentor. The scientific content has been very nicely drafted. Any conference success is decided by personal care, hospitality, scientific content, and running the show timely. So everything has been superb, and atek nik bhi na nik, so it has been so nik. God bless all of us. एक आदमी को छोड़ के सबको मेरा आशीर्वाद एंड सर को मेरा प्रणाम.
एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से. हमारे अत्यंत ही माननीय मुख्य अतिथि, आप उन्हें इस वक्त सुन पा रहे थे, डॉक्टर बी ठाकुर जी, जो कि अपने मन की बातों को, अपने दिल की बातों को हम सभी के बीच रख रहे थे, हम सभी के साथ साझा कर रहे थे, और बहुत ही खूबसूरती के साथ, बहुत ही प्रभावशाली तरीके से उन्होंने अपने अनुभवों को, अपने विचारों को हम सभी के बीच व्यक्त किया, प्रकट किया. और चलिए मैं बिना किसी विलंब के आप सभी के समक्ष आमंत्रित करना चाहूंगी हमारे माननीय ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर सुमित कुमार वर्मा सर, जो कि अब आप सभी लोगों को संबोधित करने वाले हैं, और हम लोग सभी इस सम्मेलन के विधिवत समापन की ओर अग्रसर हो रहे हैं. तो उसके पहले वो धन्यवाद ज्ञापन करने वाले हैं.
लेकिन नौका तट छोड़ चली, कुछ पता नहीं किस ओर चली, यह बीच नदी की धारा है, सूझता ना कल किनारा है, ले लील भले यह धार मुझे, लौटना नहीं स्वीकार मुझे. CCDSICon BNJ 23 being organized in Begusarai, the land of Rashtrakavi Ramdhari Singh Dinkar, is a milestone in itself. On behalf of organizing team, it is my privilege to propose a vote of thanks. Looking back at my journey as organizing secretary, I had my fair share of high and lows. It is no small task of putting wheels into action. But the success of this event does not rest on my shoulders alone. I would like to thank all delegates and distinguished speakers for sparing their valuable time to grace the occasion and for enlightening us with their talks of various subjects. I would like to thank my friends and colleagues who took out time from their busy schedule and attended this event. I would like to thank the chief guest, Dr. B. Thakur sir, the guest of honor, Dr. S.K. Lal sir, Dr. Kamlesh Tiwari sir, our founder president, Dr. A.N. Rai sir, organizing chairman, the Pramod Kumar Singh sir, the chairman, Bihar and Jharkhand, Dr. Umesh Khan sir, chairman of scientific committee, Dr. Ajit Kumar Sinha sir, chairman, reception committee, Dr. Binay sir, national secretary, Dr. Mrityunjay sir, and secretary Bihar and Jharkhand, Dr. Abhishek. I extend my thanks to members of IOCL for granting us the venue for organizing CCDSICon. I would like to thank all the pharmaceutical companies, media man, administration, IMA, API, and IDA involved in this event. I sincerely apologize if I missed anyone. This journey has been enlightening for all of us, both on professional and personal front. I look forward to all such events which will put Begusarai on map of learning. Thank you for your patience hearing.
I like to have one announcement that in Jharkhand, Ccdicon is going to be held on 28th, 29th, and 30th of April. You all are requested to please come and join the conference. Thanks.
So once again, thank you so much to all the honorable patrons.
Jamshedpur.
So once again, heartfelt thanks to all the honorable dignitaries for gracing the dais. And I would request all of you to kindly put your hands together for all these really amazing and inspirational personalities. And as all of you are already aware of the fact that we are heading towards the formal end of this very amazing conference. But before we do that in a formal and official manner, we are going to have our national anthem. And for that, I will request each one of you to kindly get up at your respective places. आप सभी लोगों से अनुरोध है कि आप लोग अपने अपने जगहों पर खड़े हो जाएं ताकि हम लोग और पुनः मैं आप सभी गणमान्य अतिथिगणों को बहुत बहुत धन्यवाद कहना चाहूंगी। आप सभी